going to be presenting today. He's a practitioner here in the Cypress, Houston area. I've been working with him closely for a couple of years now, and he's actually done this presentation a couple times for us, and it's really amazing. So you guys are in for a treat. If you need anything, Allison and I will be in the back. So without further ado, Dr. Hayden, thank you so much.
Thank you. All right, everybody. Perfect. Oh, no, go back. Perfect. 3 seconds in and I've already messed up. All right. Hey, everybody, I'm Chase. Thanks for coming out. Our goal today is to make sure you can leave with tools that you can use on Monday morning. It's the number one thing we want to be prioritizing. There's nothing worse than going to a conference or a lecture or something and getting a lot of good information that you go home with and you just scratch your head and say, how do I even do this now? How do I incorporate it into practice? Christy mentioned a second ago that we have had some phenomenal workshops lately. So like Greg taught this one. Who's the other teacher? So Greg was a big part in the heart sound recorder testing that we did. We liked the idea of being able to come and learn, but then also do and take home what we have and implement it into our lives, right? So today there will be some philosophic discussion of why we do what we do, as well as some clinical application that you can use on Monday morning. And there will be some things that are a little bit different that maybe you've seen before or maybe you haven't. But let's get a little bit of a lay of the land, because this is nothing worse than me just talking for 4 hours straight. So I want to know what y'all have. I want to know questions. If you have questions, just ask them and we'll answer them and we'll just make it happen, okay? But to begin with, how many of you have been in practice for less than 5 years? Raise your hand. So about 7 of us, okay? How many of you have been in practice for 5 to 15 years or so? 3 of us. Anybody over 15 years or so? Another 3 or 4 of us. Okay, perfect. So good. So a variety of experiences are here today. And like I said, when you've been in practice for a long time, you see a lot of things. And then you come home and you get excited and you sometimes start implementing that into practice. And then you forget all those great things that you already were doing because you're trying something new. And we don't want that to happen. But on the other hand, sometimes we walk out of a conference or a lecture and we learn something super new and we can just figure out a way to add that to what we're doing, and it just lifts everybody as a result. So the goal of this is to see how we might be able to take something from today so that you can add it into your own practice and that you don't become someone who's trying to practice outside of who they really are, if that makes sense. I'm the only Chase Hayden in this room, and I will practice the way that I practice because that's what makes sense in my own brain. And if you try to replicate what I'm doing, it'll not be satisfactory for you because it's not you. So you need to practice like John will practice. You need to practice like Liz will practice and Ashley practices. You need to be able to make it your own so that you have joy and passion and excitement behind what you do, and then your patients will get better as a result of that. The worst thing we can do is try and pretend to be somebody we're not and try and say, well, Chase did it this way, I got to do it this way, because that's not the case. But hopefully there's something here you can pick up that you're like, you know what, that'll plug right here into the way I see patients, and that'll be beneficial for all of us. So let's think about the patient experience. Hopefully, if this decides to work again. There we go. So I do a lot of applied kinesiology in my practice. Applied kinesiology is diagnostic-based muscle testing. I do full body muscle testing as well as straight arm muscle testing with vials and things. But the guy I learned applied kinesiology from was named Wally Schmidt. And Wally Schmidt learned from George Goodhart, and George Goodhart was the developer of applied kinesiology. So my family tree of AK is a little bit shorter than some other people's, but I'm super excited that I got to learn from someone who has a strong background in neurology, in biochemistry, in evidence-based care, while incorporating a different context of looking at the person. So a lot of what I do is built and hinges upon how Wally Schmidt would describe things and talk about them, and the other information that we would get from Goodhart through seminars and workbooks and things like that. So Dr. George Goodhart repeated over and over and over again that one of our most important things to do is to measure, measure, measure. Why are we doing the things that we do with our patients if we don't know if it's going to make a difference? If we think about the stereotypical like chiropractic experience, someone hurts their back, they look in the yellow pages for chiropractor because chiropractors are just back pain people. They show up to your office and they expect you to get their back cracked on the first visit, right? And sometimes people do that and they do perfectly fine with it. But what if there's something else that's causing their back to be jacked up? And we don't measure other things and we just assume that every person is a broken back and every person is a nail and I'm just the hammer that fixes things, right? So therefore, Dr. Goodhart would always talk about the importance of measuring things and not relying on the muscle test to be the determining factor. He would talk about how the muscle test incorporates into your physical exam, your history, your orthopedic findings, your lab findings, your whatever else, and you muscle test. And with all that telling you the same thing, then probably you're on the right track. And so sometimes we get excited about being the best therapeutic practitioner we can be, and we forget to diagnose some things. So I'm going to share this little quick video real fast. Hopefully it works. I've never tried using the video through this button. But hopefully it works. But it's Wally Schmidt and George Goodhart talking from back in the mid-'80s. So it's a little bit ghetto, the video quality. But it's a funny story that talks about the concept of diagnosing and looking at stuff. So let's see if this works. Here we go. Oh, why would that not work? 1 second. Pause. It's all right. We can override it over here. That's why it's not working. There's no volume.
One of the things that you really have to do is you really have to make the diagnosis on the patient. You need to assess the patient fairly what's wrong with them. Everybody wants to treat, but sometimes you have to do the diagnostic work.
Everyone wants to be a therapeutic giant. They end up being diagnostic midgets. Because sometimes we feel that we're a non-mainline profession. We feel we have to justify our business by creating spectacular results. And there's nothing wrong with that. But you are much more successful if you become a very good diagnostician. Don't try to be a therapeutic giant when you're a diagnostic midget. I had a patient come to see me who had seen the best iron nose and toad in town. Iron nose, okay. She had seen the best, Dr. Will Hudson, the best chestnut, internationally known as a lung physician. She had seen the best interns. She had a constant cough that kept her from sleeping. Cough syrup, analgesics, enzymes had no effect. Her life was living hell because all she did was cough all the time. Very hard to suppress it. And someone had said, well, maybe Dr. Goodhart can help once in a while, which could be real out of place. And some people said, I have that, and they fixed that by I quit coughing. When she came in, with a history of having seen all the best guys in our town, I assumed at the moment that they didn't miss anything. And she had an x-ray, she had all the usual tests with this constant cough. And I remember having seen one patient that had gotten a haircut, and some of the hair had fallen into her ear, and she had some wax in her ear, and a piece of hair was actually irritating the eardrum. So I looked in her eardrum, and I didn't see anything. And I thought to myself, why should I risk my reputation on the fact of their reputation? Patients coming to me, what would I do if I didn't know she had been to see all those guys? Maybe they missed something. So I did another thing, I x-rayed her, didn't find her. And I decided to start at the top. And I said, open your mouth, and I looked to see if there's any uvular deviation. Sometimes uvular deviation can be the cranial fault. Didn't see that. I checked her pupil for reflex contraction to light. I already checked her blood pressure. I've already done the other tests with her. I said, well, the logical thing is to examine the nose and check for possible turgidity of the terminates and that sort of thing. And she was lying on her bed table, or talking about that. And I had a nasoscope and simply looked in the nearest nostril. Didn't see anything. I looked in the other nostril. looking back at me from high up on her nasal septum was a bee whose eyes were pretty large, and his feet go out like this, and look right at me like that enlarged 3 diameter. It scared the hell out of me. And I said, I think we're the doctors this time. And the bee was mummified, and the other doctors in here were sitting up, and they looked this way. I looked that way. And it was way up here. And it was mummified, and I had a needle nose spectacle. Tried to tease the bee loose, and his feet were embedded in the nasal mucus. And every time I touched the bee, she coughed. And I finally looked at her and I said, "You see what you have?" And she says, the sooner was gone. She says, "You know, I remember when this started, there was a bee buzzing around from it." So crawled up there and must have stung something. Crawled up there and died, because it was mummified, pretty dry. But that taught me, always look in any orifice you can, because you never know what you're going to see.
All right. So the reason I share this video, apart from it just being a funny story, and I think it's great, is that think about all the diagnostic stuff he had to go through before getting to the solution. He had a patient, that patient went through all the specialists, and then showed up at his office off of a referral, because that's how everybody shows up in our offices. And then if all of a sudden we just stop and say, oh, well, they've already done everything, let me just shortcut to what I think is going to be the problem, we potentially miss the boat. How easy would it have been for him to just say, well, everybody else who came to see me and had these coughing things, I just adjusted their ribs, did a structural thing, and I was done with it. And then he would have done that 1,000,000 times, and it wouldn't have worked, because it wouldn't have gotten to the problem, because he was trying to be that therapeutic giant, but he was that diagnostic midget. Does that make sense? Like how we have to step back a little bit. So today, you all have opportunities to look at your patients a little bit differently. And obviously, we take a patient history. I strongly encourage specific forms of questionnaires like the clinical reference guide forms that are there that you can use, the symptom surveys type of things. I love those because they give you a broad spectrum of the patient, even though they may show up and say, you know what, I'm having back pain, but yet you have them fill out some questionnaires and they're talking about how they're constipated and only poop once a week, that when they do, it's like super hard and it doesn't move, and they get gas and bloating and whatever, and then they say, oh no, my digestion's fine, right? But their questionnaires tell you a different story. So it gives you an opportunity to dig a little bit deeper, but also gives you an opportunity to ask them if they're okay with you taking that on as part of the process. If they only want to see you with blinders on and say, nope, chiropractors only crack backs and don't do nutrition, some patients do that. And you say, okay, well, that's up to you and your practice as to how you're going to handle that. But most of the time, if someone comes in and says, I've got low back pain and I see other stuff going on, I will ask them, say, if I had a magic wand and I could fix this digestive stuff that you wrote out on all these questionnaires, would that be okay too? And they're like, yeah, but I just thought you were a back cracker. I was like, well, I can crack some backs, but we can fix some other stuff too if you're okay with it. So let's work together and get you to be healthier. So I love forms for that purpose. I like to do a lot of diagnostic labs. So I do blood work and Dutch tests and urine tests and do things like that because I think that's fun and it gives me more info. I do some imaging as necessary, so I don't x-ray every patient or anything, but if someone comes in and they're not getting better after a few visits, I'm like, that's weird. Everybody gets better when they come to see me, so let's do this imaging and see what's going on, right? So why not? And I do a lot of different physical exam stuff. My practice is built on manual muscle testing, neurologic assessment, and poking and prodding on the patient. And then I incorporate the structural, the neurological, and the nutritional side all into one big whole when I start working with patients. And so I love the idea of finding out more about people. That's why I like the heart sound recorder. That's why I like physical exam findings. That's why I like lab tests, because I want to see the whole so that I'm not missing something when I walk in and say, oh yeah, your back hurts? Let me just spend some time wailing on that for a while. Let's do something more efficient for the patient. So, oh no.
One of the things that you really have to
Time
do
out.
is you really have to make the diagnosis of the patient. You need to assess the patient fairly.
All right. So I'm reminded of this poem. Have any of you ever heard the story of the blind men and the elephant? It's a poem by John Godfrey Sachs. Anybody ever heard that before? I'm going to read it real quick because it's like super short, super fun. But this poem just kind of sticks in my mind all the time. And it says, so this is by John Godfrey Sachs. It was 6 men of Indostan, to learning much inclined, who went to see the elephant, though all of them were blind. That each by observation might satisfy his mind, the first approached the elephant, and happened to fall against his broad, sturdy side. At once began to bawl, God bless me, but the elephant is very like a wall. The second, feeling of the tusk, cried, Ho, have we here, so very round and smooth and sharp. To me, 'tis mighty clear. The wonder of an elephant is very like a spear. The third approached the animal, and happening to take the squirming trunk within his hands, thus boldly up and spake. I see, quoth he, the elephant is very like a snake. The fourth reached out an eager hand, and felt about the knee. What must this wondrous beast is like, is mighty plain, quoth he. 'Tis clear enough the elephant is very like a tree. The fifth, who chanced to touch the ear, said, even the blindest man can tell that what this resembles most, my stanzas are off. Can tell me what this resembles most. Deny the fact who can. This marvel of an elephant is very like a fan. The sixth no sooner had begun about the beast to grope, than seizing on the tail swinging on the swinging tail that fell within his scope. I see, quoth he, the elephant is very like a rope. And so these men of Indostan disputed long and loud, each in his own opinion, exceeding stiff and strong, though exactly was partially in the right, and all were in the wrong. So oft in theologic wars, the disputants, I ween, rail on in utter ignorance of what each other mean, and parade about the elephant not one of them has seen. And so when we talk about the idea of how we see patients, we sometimes come into the idea of a dogmatic worldview that says all people have parasites, all people have emotional issues, all people have subluxation, all people are in magnesium imbalance, or whatever. We make these assumptions sometimes and we miss the elephant for the parts because we put our blinders on and we step in and we say, this person has this thing because everybody has this thing that presents in this way. And I hope that today we can kind of branch out a little bit and say, you know what? Maybe there's something else going on that we can look at. So, all of us are going to have some type of philosophic foundation in which we enter practice. These are some examples. For example, some people like to have a foundational pillar of certain things like fun, rest, exercise, your environment, your diet, your personal outlook, your mindfulness. And upon that, you start then building on blood sugar and digestion or whatever. Some people walk in and say, you know what? If digestion's off, everything's going to be off after that. And there's no right or wrong answer. We all come to this conclusion on how we view the world in our own ways. In a lot of alternative fields, we think about this triad of health where we think about structural and chemical imbalance. You know, D.D. Palmer talked about it, George Goodhart talked about it. And within that, you have a variety of areas that you might use to therapeutically support those different sides or identify imbalances within those specific sides. And all of us are going to have a foundational concept in which we see our patients. I trend in this idea a lot of times, and sometimes I don't. I have a different triangle that I keep in my mind that's the neuroendocrine immunology triangle. And so sometimes I keep that in the back of my mind as I think about the neuroendocrine immunology complexes with patients, because there's a lot of research that shows that, you know, low testosterone can be a hormone issue, but it can also be a immune issue. It can also be a neurologic issue. So it makes sense in my brain that something like that could be addressed in a variety of ways. And my mind shifts through these paradigms at different times when I see patients, depending on what I'm trying to work with. But ultimately, we have to come up with an idea on how we might treat patients. Because I do a lot of muscle testing, specifically diagnostic muscle testing as taught by the International College of Applied Kinesiology, I keep a strong neurologic framework in everything that I do. Even though I do straight arm testing with vials and things, which are a little bit harder to describe with neurologic-based rationale, I love the idea of looking at the body in a different way through muscle testing. And we're going to hone in a little bit on that today as an idea of how we might support our patients. I'm going to show you some basic muscle testing ideas from a whole body standpoint before we jump into more isolated individual muscle testing with vials and things like that. There's a phenomenal paper written by Wally Schmidt and Sam Yannick about the neurologic rationale behind muscle testing. And if you get really bored and like to read peer-reviewed medical research, this is a phenomenal one to check out. But it discusses the neurologic rationale of what we do when we assess patients from a neurologic basis. Our nervous system is heavily influenced by our afferent world. The sensory input we give ourselves directs a lot of things. So we will compensate in a variety of areas, whether that means down-regulating vagal tone and diminishing enzymatic secretion from the gut, displacing peristaltic movement, or imbalancing blood flow to the digestive system due to a fight or flight reaction in our sympathetic overdrive based off of our environment. Those things will happen, right? Or hormonally, we will have downregulation of hormonal glandular excretions as evidenced through parasympathetic tone to the nervous system based off of our afferent influence. So manual muscle testing dives into that world and how does the muscle test change relative to the afferent stimulus that's given to you. And we're going to go into some more of these ideas. So before we get too far down the rabbit hole, though, let's think about normal physical exam. Every new patient that walks into my office goes through a physical exam. We're jumping into like Monday morning application now, right? So every patient comes through my office. I have them fill out about 10 pages of paperwork for their exam because it's a lot of questionnaires, it's a lot of history, it's a lot of tell me about you. But at the very beginning, I spend the highlights. I do my OPQRST like you learn in school, and then I leave those questionnaires for after the first visit because I want to look at those a little bit later and compare what I find in my exam to everything they told me about it. But eventually they get on my table, and we have an opportunity to go through some stuff. And because George Goodhart brainwashed me to measure, I do a lot of basic stuff. I range of motion, I orthopedic finding people, even if they feel like they're doing good. I just check some stuff on them, see how things are working. And remember, all y'all will get these slides. I don't mind if you take pictures, whatever, but you will get these slides emailed to you on our first workshop. I'll get them to you in just a bit. But with every patient, I go through something that is called the Nutritional Physical Exam. And I do a very abbreviated version on everybody and a much more elaborate version on other people, depending on what I'm trying to do and what their specific symptoms are. But we're going to learn this today if you've never seen it before. And we're going to give opportunities for you to practice on each other to see what happens when someone jabs on something and if it hurts. Because the theory behind these are that Chapman reflexes and viscerosomatic reflexes are going to manifest a symptomatic presentation for the patient that's on your table. And that through that compensatory symptomatic change, their body is going to tell you a scenario that we're going to go through. So I do all of the nutritional testing on everybody, but when we go further down the line, we're going to build in this idea of this hypothetical patient that walks in and says, my back's not feeling good. And how we might evaluate that low back a little bit differently using palpation, manual muscle testing, nutritional interventions, and other applications to help this patient get better. Does that make sense? So, Dr. Chapman came up with these. Boring, boring, boring. Y'all can read that later. Basically, it means we got small intestine points. Basically, you just go to the area and you start jabbing on stuff. Then you go to the large intestine area and you start jabbing on stuff. In the corners, you've got these valves where they're transitional areas where stuff tends to get stuck. Ileocecal valve, Houston's valve. We're going to just jab on things. We're going to palpate the person very similar to how you might do something else with joint stuff or whatever. You're going to do it on people. For the females in the room, we'll jab your ovaries. For the males, we won't jab your testes. Different doctor does things like that, right? So we're going to poke on areas that make sense to poke on. We're not going to poke on others. We will jab on everybody's chest, though, not just the females. We will check men and women, and we'll see what things are sensitive. And the reason we're going to do this is because we want to know where is our body giving us a symptom that's potentially messing something up. Okay, we're just going to start with this at the beginning. Does that make sense? Can we start with something like that for just a second? Give everybody a chance to stand and walk around? We're going to go around and do that for a second. No, we're not. No, we're not. I'll change my mind. We're doing something different. There are two of us that have never seen this before. Is that correct? Everybody else has seen this of some kind. Okay. Then bear with me. We're going to just go to the next section before we workshop. Because if most of us have seen this, we want to actually do something that's clinically relevant. And not that I want to mess up Terry. I can't read your name tag. I'm sorry? Simile. So we don't want to mess y'all up.
Okay.
But you're going to be good. We'll see this in a second. But the big question is, who cares? If someone comes in and says, my back hurts, and I'm jabbing around and I find chest tenderness, and I find sinus tenderness, and I find that their ovaries don't work, and I find their Murphy sign, like who cares? Does that really involve their back at all? Maybe. Maybe. It could. It could have nothing to do with everything. Nothing to do with anything. It could have nothing to do with anything. But it could be something. So it's a data point. If you can imagine puzzle pieces, we just got a new puzzle piece we added to the picture. And then a new puzzle piece. And then a new puzzle piece. And if all those start telling us the same thing, well, then it matters. And if we have, a starry night over here and a clown over here, well, then it may not apply. Unless it's it or something weird. And now they might apply, so we'll see. So we have this story. So now what do we do about it? Because I like nutritional things and I treat everybody structurally, neurologically, and nutritionally in my office, I like to figure out if there's a nutritional component to the viscerosomatic reflex that I might be finding. And in conventional applied kinesiology, there is a way to put stuff on people's tongues and let the afferent nervous system change the body. If you like reading neurology, there's a simplified picture there for you to know what you're doing. But ultimately, when you put something on their tongue, you create an afferent change, potentially, that creates a viscerosomatic response, potentially, that will change the palpatory finding, potentially. That's what we're going to play with first, okay? So now, these are all the spots superimposed into one person. These are a lot of products to play around with. So let's just run through some brainstorming in case some of us are not familiar with standard process things. Let's pretend I jab on someone's gallbladder area and they say, ow, that hurts. I then ask them, how does that hurt? It's a 6 out of 10 hurt. I say, great. If I wanted to potentially create a therapeutic thing to help that person, what's something you might do if someone's positive Murphy sign was present?
Beta food?
I'm sorry?
Beta food?
Beta food. Why beta food? It's got beets, it's got carrots, it thins the bile, it helps drain that sludge through phase 3 detoxification, right? Beta food's a phenomenal idea. Anyone else have an idea?
Cola.
Colocol? Why colocol? I didn't hear who said that.
Biosalts.
Oh, biosalts. Biosalts. So if they're sludgy and they're not creating biosalts efficiently, or they're not releasing them appropriately, either due to a stone or to just viscosity issues or whatever, I might be able to put biosalts in their line and just start breaking up some stuff for them to give them some break while they're getting some stuff through there. So maybe beta food, maybe AF beta food, because it's a combination of vitamin A and cataplex A, cataplex F, and beta food. Maybe biosalts, like colocol. Anyone else have a thought on like gallbladdery things? What's something that no one in this room would know that you like for gallbladder stuff? Something that only you use it for. Anybody have a thought there?
Essential fatty acids.
You might give them essential fats, so like the cataplex F or tuna oil or oprima, something like that, which is possibly crazy, but possibly awesome, right? Because when you think about someone who's got a stuck gallbladder, you say, well, maybe I'll give them some more fats, right? That sounds counterintuitive, but maybe that's going to work for them, right? The good news is we don't know until we try it. But is there something that just some of you think like, man, this just saves my bacon whenever I give someone with gallbladder issues something, and you've only heard it from like one person, and then you're like, I'll try it, and it worked. Do anybody have anything like that for like the gallbladder area?
I use Antrax.
Antrax? Antrax is lovely. We often think of Antrax as histamine and anaphylaxis or hives or liver things, but gallbladder drainage stuff, it works for Liz. So Liz would use Antrax off-label if she had a gallbladder stuff, and that comes from clinical experience, right? And all of you have clinical experience, and I hope we get to share some of these crazy things around. Because hopefully, if you never thought of Antrax for gallbladder stuff, you might today now write that down and say, ooh, I might need to try that one sometime. Because I've got someone with a stuck gallbladder, and I've beta food the snot out of them, and it just doesn't work. Where I've colocol them to death, and now they're getting like nauseous, and they're like burping up bile, and they're pooping black stools, and nothing's working because it still works, right? And then you're going to stick one in, possibly Antrax, and then go, holy crap, you're the best doctor in the world, I'm so glad I can visit you. And you say, yes, I'm going to tell Liz next time because that was legit, right? So all of us are going to have things like that. For what it's worth, I think Thymex. There is so much infection that just hides out in the gallbladder because when it gets stuck, I find so many people with Thymex that get better with a Murphy sign type of test that I would not ever have thought about that, except one time I was talking to somebody and he's like, oh yeah, I had these bile stones, and when they pull them out through surgery, someone got the bright idea to check for infection, and they just cultured a ton of stuff. I was like, oh, that's weird. Who does stuff like that? He's like, I don't know. The patient wanted to take the stones home. The guy was like, whatever. And she just gave him the stones like from the hospital instead of throwing them away or doing whatever hospitals do with them. And that lady like put them on petri dishes and like wanted to see if stuff would grow, and stuff grew. And she was like, oh, maybe it was really an infection that did this. And it was this weird conversation with the patient. They talked to this doctor. This doctor was talking to me one time. So now I think, maybe I should check immune stuff when people have sludgy gallbladders. And I like Thymex for that purpose. So that's some of those weird pearls that you might use, and it may never work in your practice. Maybe that's on my office where people show up in Cyprus that have gallbladder and Thymex relationships, right? Choose to not beat you. I think it's appropriate to ask people, so I ask them. But what I'm going to do here is I'm going to find some AF beta food that I brought from home because I was told we don't have any here. So here's an AF beta food, and lucky you get a brand new one.
Like you can pop it from up to down so I don't miss anything, or you have to do stuff.
No, you can do whatever you want. There's no real rule. We just make it up as we go. That's what.
I would assume the gallbladder point is inclusive of liver, correct?
Yes, ma'am. Ish areas, yes. I take them and put them in the lid, and I place that in their hand. I say, please place that in your mouth for me. This is AF beta food, real-time experience. We're going to see what happens, right? She's sucking on it. Do you taste it?
Mm-hmm.
All right. Once we've initiated a taste response, it would be plausible that we've triggered an afferent reaction in her body. So if we've triggered an afferent reaction in her body, it's plausible that pain would change. So I'm going to attempt to do the same thing, same pressure, same location, because I'm trying to be moral, honest, and ethical in what I do. I don't just want to sell AF beta food, even though I don't mind when I sell it, right? Does that change that, or is that about the same?
Even more.
It hurt worse. I would have a hard time giving someone something that hurts worse, right? If I come over here and jab on this, did that change?
A little bit.
A little bit. That's weird. Why might AF beta food, the liver gallbladder supplement, hurt worse on liver gallbladder area, but possibly make lower abdominal / ovary area better? The answer is, I don't know. Right? Yes, ma'am.
Could she be
Can you spit that
a
out for me?
little sensitive from the previous palpation?
She definitely could be, yes. And so normally I don't jab on people for like 10 minutes straight on the same spot. It's just a quick thing where I'm like, oh, that hurts, and I write it down, and then I just start trying stuff on them, and then I test it out again. So it's possible that she's just being irritated. But she said a second ago that the more I mess with it, the better it started feeling. So I wouldn't expect it to feel worse as a result of that, based off of what she just mentioned a second ago there. But it could be, I don't know. I mean, we'll just see what happens, right?
I just wondered if it was a rebound too.
Right. Now, going back to the ovary thing, potentially essential fats help with things, potentially vitamin A helps with things, potentially calming down liver, gallbladder stuff could help with other areas. So that's the awesome thing about standard process is you almost can't go wrong. You can only just be a little bit more right in our approach. Does that make sense? So just keep that in mind. So you can't really be wrong. If she walks out of here with 5 different things that are all whole food based, supportive to what we found in our diagnostic evaluation, and she starts taking them, have we done her harm? No. Who really eats enough beets in their life? Like besides all of us hippies here right now, like nobody eats beets in our lives, right? So therefore, if I give her stuff that has beets and carrots and liver and all those awesome things inside of it, it's only going to be therapeutic. It might be like this therapeutic rather than this therapeutic. And so I'm striving for this because I want her to go home and tell all her friends to come see me and buy her supplements from me instead of Amazon. Like I want her to have a wow experience where she says, holy crap, Chase, that was amazing. I need to tell everybody I know about you, right? So I'm trying to get that. So I want to be as most right as possible. But if I'm accidentally not as right as I could be, it's not harmful, okay? So in this scenario, AF beta food sounded good clinically, but may not have done what we wanted it to do. So we're gonna experiment with something else. Anybody want to throw out something? Is beta call a bad idea? Is it possibly gonna be good? Possibly. It just happens to be the first one I saw, so we'll grab it. Now I have people, even through the capsule, stick it in their mouth, and beta call has some Spanish moss in it, has some B6 in it, has some bovine liver in it, and beets and other things, hydrochloric acid. Do you taste something in there?
Mm-mm.
Just suck on it till you get, I know, but I'll let people just suck on it for a second. There's still residues and stuff in there to where her nervous system is perceptive of it. But I'll have her suck on it for a bit. Did that change anything?
Better.
A lot better or a little better?
A lot better. No feeling.
No what?
No feeling.
Tell everybody in the back that may not hear you.
No feeling.
No feeling. So we went from a 2 out of 10, AF beta food worse, beta call 0 out of 10. If I come over here to the ovary area and I jab like that,
No feeling.
no feeling?
I have a question about this area because
Yes.
the vagal
Do you wanna spit that
nerve
out
is
for me?
not that sensitive.
The what nerve?
The vagal nerve is not that sensitive.
Right.
So how could you know this not like a
I don't.
Okay.
I don't know. That's the cool thing about it is we can't be so locked in and say because this one spot hurt, it must be ovary. Because we don't know that. We're doing an evaluation to evaluate what might work and what might not work. Because I have to go through skin, muscle, ligament, tendon, bowel. I have to go through all kinds of stuff. And it seems to be that these certain areas have a strong correlation to certain body parts as a visceral somatic reflex. But it's the exact same thing where you say, hey, I've got tinnitus in my ear, what fixes it? What fixes tinnitus? Tinnitus. Lots of clinical experience with a lot of clinicians throughout the world and people since 1930 with Dr. Chapman and forward. It seems to be that people respond well when we jab there with ovarian type support. So we're gonna play with it. And we're gonna walk out of here thinking, dang it, we don't really know anything as doctors. Because that's the craziest thing about it. Thank you very much for being a guinea pig there. And the neat thing was we found one thing we thought would be just brilliant based off of our discussion, and then we found a different thing that we said, oh, that really changed it. Yes, ma'am.
Would you stop testing these supplements at that point, or would you continue after you found something that worked?
Depends on how much you want to sell. No, I'm just joking.
I understand that.
No, I'm just joking with you.
Correct answer.
Right. So what I do is I test all of these on everybody before I start doing oral challenges, and then I'll do an oral challenge and retest the ones that were out of range. So even though beta call doesn't make sense for ovaries, it changes something.
What could bring the ovaries, but large intestines?
Exactly. So therefore, I'm not so dogmatic to where I say, oh, the ovary spot happened, I can only use these 6. Gallbladder spot happened, I can only use these 6. Therefore, I'm going to give you 1 from this column, 1 from this column, 1 from this column, etc. I will sometimes like AF beta food will fix everything, and I'm like, that's so cool. I only get to give you 1 pill to change all of these spots and bring them all down to 0. But sometimes I'll do 1, and then like half of them get better and half of them don't. Then I'll do another one, and some of those that got better got worse, and another one didn't. And we have to use doctor clinical judgment at that point to try and figure out what is the most appropriate thing at this time based off of the whole picture that we see. And so for some people, there might be 2 or 3 that I've checked that make a systemic change, and I will do all 3 of those or
Right.
whatever I might
So
do.
I just wondered, like, after you use the beta call and it completely, everything's remedied at that
Right.
point, do you continue testing?
Oh, yeah, rarely if they get down to 0 and 0 on everything,
Right.
I'm like, that's the thing you really need. And this is one puzzle piece, like I said, that's going to go into my clinical presentation, because I haven't even done anything else other than take a history and just palpate a little bit on them and do some oral challenges. And just like I'm kind of joking around with y'all, I joke with my patients, like, we're going to do something, I tell them, we're going to do something weird that no one never has done to you before today. Because if I do the same thing as all those other doctors, we're going to get the same results as all of them. Now, you don't want that, because that's why you're here. So therefore, we're going to do something a little bit different. You filled out 4 million pages of paperwork. That helps me after this visit as I review everything. Today, we're going to figure out what your body has to tell me. We're going to start hurting. Oh, jabbing on you. Oh, that hurts. Oh, I'm sorry to hear that. Okay, no, keep on going. Put this in your mouth. That's weird. I know this is weird, but put it on your tongue. We're trying to create a neurologic reflex. They put it on their tongue, feels better. They're like, how did you do that? I'm like, yeah, magic, wizardry, science, I don't know, pick whatever you want. But it worked, right? So then they spit it out, and I go back and I jab on it again, and they're like, oh, it's hurting again. I was like, yeah. If you were the doctor, what would you do? I asked them, they're like, I'd give me that. I was like, I'm probably going to give you that. And they say, okay, cool. And we go on again, and we try it again. And we do these things over and over again, trying to figure out where they're at. And then I set those aside. I have like 2 shelves, and I just set the ones that worked on a different shelf. And then I do the rest of my exam, where I'm doing orthopedic findings, or I'm doing muscle testing, or I'm doing something else. And you know what? If I'm doing like a knee problem, and I do like an anterior drawer, and they're like, oh, that's sensitive. And I do like that one where you twist it, McMurray sign or whatever, and that hurts. And they're like, oh, that hurts. I'll grab one of the ones that made something better if it sounds like clinically relevant. Like if something has a bunch of calcium in it, like hypothetically, or essential fats or whatever. I'd put that in their mouth and redo those orthopedic findings, and they'd say, wow, my knee, that didn't hurt my knee. The grinding didn't hurt that time. That's weird. I'd say, yeah, it is. Would you give that to you? And they're like, yeah, give me that. I was like, good, because we're going to give it to you, right? But what if none of those things had already worked, or it doesn't make sense? Like beta call, I can't think of beta call and say like, I lied. Let's go back to this knee thing. If I have like a positive orthopedic finding, I think gallbladder can go with unstable knees and unstable necks and stiff knees and stiff necks, because it's another viscerosomatic thing, right? So now if I do an orthopedic test because someone's like, I have runner's knee, and I also found gallbladdery signs, I am 100% going to grab beta call off if it made everything better, put it on their tongue, and recheck their knee again. Because I want to know, and I want them to know, that the supplement I'm going to give them is going to make them better. And they're going to say, but I didn't come for you for supplements. I came for you for my knee. And I was like, I know, but it made it better. And they're like, you're right. I'm going to take your supplements. Please sell me more. And I say, okay, if you insist. Right? And so that's what I would do. So I'd use this challenge concept in everything I do in practice, not just when I'm doing my 5-minute physical exam at the beginning with palpation. Because this concept neurologically changes afferent activity to the body, which leads to downstream changes in muscle function, in downstream changes in organs and glands. So if I can change the way their brain perceives their world by feeding it, then that runner's knee will change, that back pain should get better, their digestion should improve, their kids should start cleaning up after themselves. Everything just gets better in their life as we get them better, right? So that's what we're looking for. Yes, ma'am.
So this is the initial exam. What about they come in for a follow-up? So now they've been taking your tests.
Mm-hmm.
You're going to do the whole thing over again?
Sometimes.
Bolus and resupplement?
Sometimes. I usually do people in 30-day supplement blocks. So say, this is your program for the next month. Good luck. But because your back and your knee hurt, come back and see me next week so I can crack some things up and do some structural things or neurological rehab things or whatever else I might be doing with them, right? But I like to allow the physiological timetable of healing to occur before I change stuff up. And so even though I do a lot of muscle testing, and sometimes my nutritional recommendations are built off of some muscle testing things, I have a hard time in my mind saying, hey, guess what? Last week you tested for iron because you're anemic and your blood work says you're anemic, and today you didn't test for that, so you're probably not anemic anymore. When I know that the lifespan of a red blood cell is 120 days, and I know that it's impossible for those pre-generated circulating red blood cells to magically have 33% iron saturation to their tissues when they were built in inefficient ways. So I will tell them when I give them stuff like, because you're anemic on your labs and because you're testing for certain things, we're going to start on this for 30 days, but this program will be a minimum of 4 to 6 months. And I might tweak it a little bit at the 30-day mark or the 60-day mark, depending on how you test. But keep in mind, we're going to be working together for a bit. And so I'll just expectation manage that at the beginning. But sometimes, if they're like I have an acute gallbladder, like I'm going to have surgery tomorrow to remove my gallbladder, what can we do? And I'll do whatever I'm doing with them. I might bring them in 3 days and recheck it all again and say, okay, cool, it's still 0 out of 10, we're on to something. Or, oh man, it was 0 out of 10 on our exam, and you've been taking these for a bit, but it's now up to like 3 out of 10, even though you've been taking stuff. Maybe I need to be a little bit more aggressive now. And so, case by case, I might do the exact same thing, but a lot of times I don't like to change nutritional things until their body has a chance to start doing what I want it to do. Yes, ma'am.
On the nutrition side, is there a part of it that you support with the change in diet in addition to the supplements?
Only if I don't want to sell as many supplements, I'll change their diet. No, I'm just joking. No, I change everybody's diet all the time. Yes, ma'am. I like to have people track their food a lot. On the first visit, I always tell people it's my exam visit, and sometimes I'll do some adjusting or give them some supplements or whatever to get started with, depending on how things are going. But most of the time, I wait till my next visit, and I give them the homework assignment to start logging their food, because I like food logs a lot personally as a data puzzle piece. And so when someone starts logging their food, even if they're not trying to lose weight or whatever, I'll just log it so I can see what macros are doing and things like that. And then when they come in as my next visit, when I'm laying out the plan, we'll sift through MyFitnessPal or whatever app I have them downloaded on, and I'll talk about what I'm going to change with them. I'm going to give them their nutritional program, and hey, I need you to get off of these foods and eat this way, and do that for the next 30 days.
That's what I was wondering. I mean, because this is only going to support whatever else they're doing on the
Correct.
side. I mean, if they have such a bad diet, I mean, these are great, obviously, because they're standard processed and they're whole foods.
Right.
And I love them. But if they're out in an ultra processed food nightmare,
Right?
the rest of the time,
I'm gonna-
that's for me as
I'm going to steal this from you real fast.
Yeah.
No, not you wrote notes on this. Can I borrow yours since you don't have notes on yours?
You may.
No, this is great. I didn't want to write anything from you. Thanks. I have a whiteboard in my office that I love drawing on because I like to hear myself talk and I like to educate people. You won't be able to see this super efficiently, but I draw this chart on people where I just make a big U like that. And I say, hey, I want you to imagine your diet, your lifestyle, your sleep, everything's over here. If you're doing really well on that, you probably will need fewer supplements from me. But if your diet and lifestyle and sleep suck, I'm probably going to give you 1,000,000 pills. And I'm like, so I want you to be aware of what we're about to do here because you're either going to be involved in how you get better or you're not. And therefore, whenever they leave on the first visit, I'm saying, I know this is 1,000,000 pills for now, but right now, we're changing our diet. We're changing our lifestyle. That's right. And I tell people all the time, if you don't like broccoli, don't worry about it. I have a bottle of broccoli in a pill that I will give it to you. And for only $43 a month, you can eat broccoli, and that's fine. Or you can modify your diet, and it'll be fine. So same thing with fish. I don't like fish. That's fine. I've got Oprima, I've got tuna fish oil, I've got cod liver oil. We'll make it work for you, right? So I draw this up for them as a conceptual idea that says, I'm expecting you to do stuff so that we can work me out of a job. But right now, you've got a dumpster fire going on in your body, and I need a lot of this and a lot of this, and we're going to make some changes. Okay, and it's a quick little conversation to have, and people laugh about it, but it makes sense to them when they can see why I'm doing it, because I'm going to give people pills. I have no problem giving people supplements. And if I give them supplements, and it happens to be 12 supplements, and they walk out and they're like, man, my bill was $500. I was like, okay, go have surgery then. There's 50 grand. I mean, I'm not that flippant on the first visit at all. But I mean, it's a realistic conversation. Like, we're trying to change what your body's not capable of doing. Right. And I want that to be conceptually taken care of, right? Like, I'm trying to get them to work me out of a job. Realistically, I want that to happen. Because I want them to say, man, that guy changed my life. And you're not going to see my kids, my husband, my neighbors, my yoga partner, whatever, because everybody's going to come see me now because we made a change in them. Does that kind of make sense? So I like to draw that kind of stuff up for them. Thank you for letting me borrow your notepad. And you can have that for your own records.
Can you sign it?
Later. But yeah, so that's kind of what we're looking at. Does that make sense? So now, how does this work in your world? Because y'all aren't me. You're not going to say flippant things to your patients. You're going to be nice and respectful like a real doctor does, right? So you're going to have to say, how is this that might incorporate into your own clinical relevance? I don't think this is hard. I do this on every new patient. It takes me somewhere between a minute or two to poke on every one of these places, get an exam identified, have a conversation about how much pain was really there, if there was, if there wasn't, and I just move on. Like, it doesn't take much to add this 2-minute slot into my exam. Maybe it jumps up to 5 minutes if there's a bunch of places and I'm doing multiple pills and the first couple aren't working. Like, I put AF beta food in her mouth and it didn't help. Okay, that's weird. Well, that just added an extra 30 seconds because I have to have her spit it out, get that down, get a new pill, do another one. So it might take 5 minutes, but it's really not a time-intensive process for me to evaluate the patient in a new way that no one else is looking at. Because remember, if we do the same thing as everybody else, we'll get the same results as everybody else. But if we can do something a little bit different and see their body a little bit different, now we're finding mummified bees up in places in their nose that they've never seen before that are causing all kinds of havoc. Sorry, you missed the video at the beginning. Oh no, you were here. You saw it. So yeah. So that type of thing is what we're looking at, right? Like, how do we see the person differently than everybody else who says, good luck. Take this multivitamin and a fish oil and you'll be fine. Let me just adjust you 30 times over the next 2 months and you'll be fine. Let me just put you on the same parasite cleanse I give everybody in my office and you'll be fine. Like how do we step back and see the patient for who they really are and just start doing something that helps them when they've gone to everybody else who does functional medicine or nutrition or chiropractic or AK or whatever, right? And this is the cool thing about tailoring the exam to their specific needs. I've been rambling way too long. Let's do a break. Everybody break. We're not really breaking. Workshop, find partners, break if you want to break, but let's play around with some stuff. Cool? I'll ask questions along the way if we need to. Whew. If you're putting supplements in people's mouths, there are little cups here. By show of hands, we're able to palpate somebody and find something that was off. Was everybody able to find somebody that had something off? And imagine who you're palpating on, right? Your clinicians and nutritionists and healthy, crunchy people and doing all these nice things in your life. But yet, even the best of the best in Houston are finding stuff with us. So this is a common thing to find, but it's often a common thing that we miss as well because we just don't look for it. And so imagine, hypothetically, you take your car because the check engine light comes on and you need new oil. So you just roll into the dealership or the auto repair place, whatever, and you say, my oil light came on, I would like my oil changed, please. And they say, sure. And as part of our oil changing experience, we're going to do this 134-point inspection to make sure that your car is fine, right? And all of us look at that and we go, man, you're just trying to take my money. I don't want you to look at my car. I don't want to change my air filter. I don't want to do anything else. But they do it anyways. And they come back and say, hey, we changed your oil. But I want you to know that your brake pads are grinding on your rotor and you've got this thing that's messing up this. You probably should take care of that. And you'll say, screw you, you're not taking my money, and you're going to drive off as fast as you can, right? Or you might say, wait a second, I didn't know that that rotor was having that issue and that those brakes were messed up. And if I wouldn't have known that, I would create more damage to my car. I'd put my family and myself in jeopardy whenever I try to brake and it doesn't work properly. Man, thank you, guy that fixes my car and changes my oil. I'm appreciative of you taking the time to look into it and giving me the option to choose for myself. Can we not do that with healthcare? Like, now, am I making every person come up here that hurts on their gallbladder take a pill? No. I find information and I tell this person, hey, I know you came to see me because your back's jacked up and we're going to do some great things to help you with your back. You tracked your food since last visit. You made some dietary modifications that I'm going to recommend to you. But because these spots hurt, I think your back can improve along with these other things. So therefore, my recommendation today is you see me for chiropractic in this way, you modify your diet in this way, you take these pills in this way, and over the next 30 days, I fully anticipate a much better outcome as a result of what you're doing. And they say, of course, Dr. Hayden, I would love to. And they walk out and they buy what I ask them to, and they schedule like they're supposed to, and they never miss an appointment, and they eat exactly like I asked them, right? And it's just the optimal patient experience for all of us involved. And sometimes they say, yeah, I'll think about it. And I say, that's fine. And I crack their back. And they come in and they get some better. And then they say, man, you're a really good chiropractor. I'm like, I know. I'm a big deal on my website. And so therefore, because we did so good on this, they may say, you know what, you told me before that I might need something else. And my back's feeling really good right now. But I noticed that, like, you might be able to help me because I get bloated and gassy and constipated. Can you do that too? I was like, well, you know, sometimes. Some patients respond really well to that. And I just take them where they're at. Some people take supplements and change diet and get back cracked on the first visit or first series of me talking about it. And other people say, you know what, I'm just going to use you in the box that I think you belong in, which is the chiropractor box. And I'll do whatever I need to do elsewhere. And whenever it's time, I've established a relationship of trust with them. They like my jokes. They come back for more, and they say, you know what, can you help me with other things? And I say, sure, we'll help you with whatever you'd like us to help you with. Because my goal is to help you achieve the level of health that you desire. And I'm very clear with that on the first visit. It says it in my new patient paperwork, and I underline it for them. My goal is your goal. If your goal is back free through chiropractic, I'll be the best chiropractor you know. If your goal is lose 10 pounds, have more energy, have better sex life, have my kids clean up after themselves, I'll do what I can to help in all of those areas. But that's going to mean we're going to change your diet, we're going to change your sleep patterns, we're going to give you supplements, we're going to adjust you, you're going to bring your kids in so I can work on them, and we're going to do all those things together, and we will see if I can help you with your goal. And to do that, I'm going to be willing to step back and see you as the chiropractic me. Now I'm going to take that hat off and put on my nutritional me. And I'm going to take that off and put my neurologic me on. I'm going to see you in a bunch of different lenses so that I can give you the best recommendation possible so that you can get the outcome that you desire. So this is why this exam is done on all patients, even if they just have their chiropractic hat on whenever they walk in and see me. Because I want to know what's going on with them so I can be better informed and help them get what they want out of their life. You've got a cheat sheet you can use. Someone asked earlier, if I'm just starting right now and I've never done this before, where would I start? If tomorrow I went back into practice and I've never done this before, I would start poking on people. And I would give myself 2 minutes per visit to just experiment with it. I don't want to disrupt the flow of my life, but I'm going to just start something new and say, you know what happens when I actually do this to you? And if I start finding stuff, then I might consider doing something more. If I only find stuff on workshop Saturday, whenever we're all here doing it together, then maybe I think, that's weird. But maybe I'm finding this on normal patients too. So I'd start with that. If you've never sold a supplement in your life, if you've never used palpatory findings in your life, and you wanted to start somewhere, just start touching people and see how they do. Then what I would do is pick the areas that you think have the broadest reach. I like AF Beta Food as a very good, does a little bit of everything product. And so if I just wanted to experiment and buy $200 worth of something to try it out, I would include AF Beta Food in my life. I'd probably do chlorophyll complex in my life. I'd probably do Enzacor or Multizyme because everybody's digestion sucks. I would do some of these things and I'd just get a couple of them and I'd experiment. It's a low cost, low time, low stress way of saying, could I potentially add this with my patients and find value? Because if I can find value, then now it makes sense. If there's no value there, then don't do it, right? So now I've got a couple of things, and even if I'm jabbing on everybody and I stick AF Beta Food in their mouth and I get a decent amount of change, I'm like, okay, maybe you need AF Beta Food. I would then sell that bottle of AF Beta Food that I purchased to them, and I wouldn't take any profit, but next time I'd buy 2 bottles of AF Beta Food. And I did that when I started my practice because I didn't have enough money to do supplements. So I took a credit card out and I was like, okay, Chase, you're starving, you got no patience, you got 2 kids at home, and a wife who wants you to come make a living for her. I experimented with $500 worth of supplements, and that's all I could afford. And I bought $500 and I said, I'm not gonna take profit from any of these supplements until I have enough to just generate my in-house store. So when I'd sell a supplement, I'd write it down on a sticky note and I'd say, Stephanie, my wife, we can't take profit from this. I have to take this $45 and spend it back on supplements again. And I just do that. And over again, my little inventory started growing and growing and growing. And now Liz spends all my money on supplements every Monday. She just spends it all on supplements. That's all we ever do, is buy more supplements in our office. But it's so fun because it's great, because I like helping people with real food-based things. And Liz runs my life, and she spends all my money, just like my other wife. No, Liz is great. She's awesome. But Monday is supplement order day. So I just hear my phone dinging all the time when it's like, oh, standard process, this much money, oh, this supplement company, this, and it just dings over and over again over lunch. It's great. But it means that we're helping people by getting them doing the things they need. And I've been able to build up that inventory by just slow, steady time. I didn't walk out and spend 20 grand on supplements on day one and say, all right, let's see if this thing that Chase taught me works. That'd be moderately crazy. Don't do that. But see how you can implement it through practice. There we go. All right. If you like reading boring sciencey papers, this is another good one that's less boring. It's called The Mechanism of Manual Muscle Testing as Proposed by the Ventral Horn Theory by a guy named Michael Allen. Michael Allen is a diplomate in neurology from the Carrick Institute. He's a chiropractor, and he's very trained in applied kinesiology. And basically, he wrote a paper describing on how manual muscle testing, diagnostic manual muscle testing, is another window into the nervous system. And because I like to look at things neurologically speaking, and I like to do neuro challenges like through taste, I like things that support what I do because it justifies me sleeping well at night on why I do weird things with my patients, right? So I like this. So today we're going to go through some stuff, but we want to kind of lay down some frameworks when it comes to manual muscle testing. There are 2 styles of muscle testing, and this might be a new concept for some people. 3 styles of manual muscle testing. Sorry, 3 styles. The first style is the style that we all learn in orthopedics class in school. John, can I borrow you for a second?
Yeah.
You're going to sit right here for me. And we're going to do the manual muscle testing we learned in chiropractic school, probably around try 5 or 6 or so, where we had the patient sit and we saw him walk. And as he walked, his feet and toes moved. So we said, okay, L5 and S1 are perfect because he doesn't drag his feet and he has good movement. We can ask him to lift his leg up. No, I'm sorry. Lift your knee up off the table. There you go, like that. So he has hip flexion. His L2, 3, and 4 nerves are probably working fine. Hold strong. 1, 2, 3, 4, 5. Good. He's got normotonic myotome activity on that leg flexion. We've all seen that, right? This is more or less what you learned in school. Lift your leg up and hold. 1, 2, 3, 4, 5. Good. We'd have him push his leg forward. 1, 2, 3, 4, 5. Good. We are strength testing. If he had a severe disc injury with atrophy and problems, his orthopedic doctor, his primary care physician, his neurologist would do this style of manual muscle testing. Is everybody familiar with seeing that and thinking back a long time ago when we were all in school? That is not what we're describing. I don't muscle test this way in my office because I don't need to know if we can bench press more than the other person. He has strength. I'm looking for a different type of manual muscle test. I'm looking for the neurologic association to the muscle, and can that muscle be told neurologically how to function, not how strong can you be. Okay? Lift your leg up or sit up like that. So whenever I go and I test people, I make it very clear to them, this is not a strength test. I'm not trying to see if you can out bench press me, because I'll win. I want to know, John Strong, he would win. I want to know how the nerve is communicating relative to the nervous system to talk to that muscle. So I'm going to try to prioritize the muscle fibers in the angle in which they're in. I'm going to apply enough pressure to stress that muscle, and then I'm going to give just a touch more. But I'm going to remind the patient that you don't need to try so hard because we're just looking for a neurologic lock. And so, for example, it might look like this. Hold your arm like this, and I want you to just focus on this muscle right here and gently press up to the sky. And that's going to be my muscle test in this scenario. And it looks like I'm not doing very much, but I'm just getting a lock. Okay? If I have him do something like this, gently press down, you're using this muscle right here, push down. I would never test from behind his back like this. I'm just doing it so y'all can see what's going on. But when I'm doing full body diagnostic muscle testing, looking for neurologic-based activity, that's the style I'm going to do it. I'm not out of breath. He's not out of breath. Everybody's happy. There's a third style of muscle testing, which is more of an energetic-based muscle testing. And many of you have probably seen something like this, where someone takes your arm and gently presses on you and then does something like touches you on the forehead and causes weakness, or doesn't push on them and they're back to being strong. This is a different style of muscle test. We'll do some of this at the very end of the day if we get bored and have time. But sometimes jabbing on different body parts and messing with people and challenging a muscle can do something to the body. And if we find something that causes weakness, that might tell us something about them. It might tell us nothing, but it might tell us something. So as we're thinking about how do we look at the person a little bit differently, and try to incorporate different puzzle pieces in their life to figure out how we can be the best clinician for them, we talked about afferent-based palpatory findings. No muscle testing involved. No subjective activity from the doctor. It's all patient-led. When I jab here and that hurts, the patient's doing that. It's not me influencing it. When I muscle test, now I have to figure out this dance of, am I pushing harder? Is he pushing harder? Are we in the right? Like, we have to figure each other out, and it's a little bit more involved. So thank you very much, John. You crushed it. You got something going? No, I'm just joking. So there are certain parts where we can touch people and get changes, but what we're going to start on right now is the standardized way of diagnostic muscle testing in a couple of areas. And we're going to look at this concept that muscle testing can tell us something, but it doesn't tell us everything. And that's the hardest thing, I think, for some of us to get sometimes, because we like have a muscle test and we hold a vial or we touch a point and we're like, oh, you've got a parasite. Maybe. Maybe you don't. Oh, your quad is weak. Your small intestines must suck. Ooh, maybe. Then maybe the hip's out of whack. Maybe the quad is weak. We don't know. We have to use it as a portion of the story when we're evaluating people. One other thing here. Strong versus weak will mess with people too. So we're going to introduce some new terms in just a second. You can see these slides later, they're boring. So diagnostic muscle testing. Be mindful of things. Hey doc, I dislocated my shoulder yesterday. Cool, let's muscle test your shoulder. Oh, everything's weak. Okay, your digestion must be off. Maybe, it could be, but it could be that they had a recent injury, right? We have to take things into consideration. If we position the person in a good place and try and isolate and focus on the muscle we're messing with, that will help us a lot. Observe in which the patient tries to compensate. You notice whenever we did our first version of muscle testing, he lifted his leg up, he like scrunched down, I pushed hard, he pushed hard. We were using every muscle we had in all of our bodies to try and test that, right? And it was a poorly done test, even in the standardized way of doing muscle testing through multiple fields. But that type of thing we want to be looking into, right? We're just trying to keep things consistent. So, there's a cool guy that wrote a book named Hans Garten. He said the main and most notable change from the past was that the muscle test became less an assessment of contractile strength. That's how we all were taught manual muscle testing in school. How is contractile strength doing relative to the patient? And that's how it still continues to be perpetuated, and it's a terrible way of assessing the body. You have to have like full-on paralysis and huge amounts of neurologic damage before someone starts developing drop foot, right? Like there's a huge injury that has to happen there. But functionally, we have a lot of compensations, and that's why this says more of an assessment of proprioception, spinal and central nervous system regulation, and the effect they have on neuromuscular function. It's that picture we saw a second ago with taste affecting motor neurons, extrapolated out to how we're going to test people. So, let's introduce some terms. Can I get another volunteer? Terry, will you jump up here for a second? All of us have been through some level of education regarding the health of patients. We're going to have you sit facing that way, please. Thank you for being a guinea pig on your first day, learning new things from us.
I prefer not to use the pig thing.
Thanks for being a guinea person. We've all seen deep tendon reflexes. When evaluating the nervous system, there are three main ways we can access neurologic function in the body. We have deep tendon reflexes, we have myotome evaluation, that's motor nerve, motor activity, and we have dermatome activity, which is skin sensation stuff. If we all think back to a long time ago when we went to school, those are the three ways you can neurologically assess somebody. Those reflexes are natural and innate, and we shouldn't be able to override them. So if I take my hand and I hit her in her leg and she kicks appropriately, I have three ways to grade that reflex. I can say it's normotonic, which means gives us the right response that we expected. It can be hypertonic, like I hit her and she kicks for 5 minutes. Or it can be hypotonic, I hit her and she does nothing. Everybody remember some level of diagnostic evaluation like that at some point? Perfect. We can grade muscles in the same way. If I take a muscle and I test it, and it appears to be strong or facilitated, I now know that's either normotonic or hypertonic. I don't know which one it is, but I know it's one of them because it was facilitated. It did what it needed to do. Whereas if I push on her arm and it goes down and she is unable to resist my pressure, that muscle is now hypotonic. See how we're using words that aren't strong or weak? And the reason we're using them is because sometimes we need to manipulate the muscle to know if it's working properly. So, if I hit her leg here, in the right spot, and she kicks, normal reflex, normotonic response. If I test her arm, and she holds just like this, and I gently press down on her, and she's strong, I at least know she's not hypotonic. But I do not know right now if that's normal or if it's hyperfacilitated. I must do something else to find out that answer. And sometimes, even though we have the best intentions at heart, our muscle testing sucks. And it sucks really bad. And we don't get good information from you people. And it's inconsistent with what we're doing. Whether that's this style of muscle testing, where we're trying to poke around and test people, or this style of muscle testing, where we're trying to evaluate myotomal activity, sometimes we just suck at what we're doing. And I don't mean that in a hurtful or harmful way, but we get bad data and we make bad decisions off of that bad data. And so hopefully we can kind of square it away a little bit. You crushed it. Thank you very much. You did so good, guinea person. All right. So how might we be able to differentiate hypertonic from normotonic if we're walking in with the patient? We're just evaluating them. They come in and they say, hey, my back hurts. And you say, great, you're in the right place. Because everybody's in the right place when they show up into your office, right? Until they come to mine. Then they're really, no, I'm just joking. Everybody's in the right place. They're here. They're ready to be changed. You do your normal exam. You've taken your history. You've palpated them. And now you want to do something to know if their body is capable of giving you good information throughout the rest of the exam. What we're going to introduce today is an idea to figure out if a patient is testable. And we're going to use diagnostic muscle testing as our baseline. So can I get a new guinea pig? Someone who's never been up here before, a guinea person. Come on up, thank you. So what we're going to do is I'm going to show you with the rectus femoris muscle. And remember at the very beginning, we talked about this being the hypothetical low back pain patient. If a patient comes in and says, I've got back problems, can you have a lie down right here? Head this way, feet this way. I'm going to have the person evaluated in nutritional, neurological, and structural ways. So I might do my range of motion. I might say, hey, let's see what happens when I do this. And you let me know if something hurts. Oh, that looks pretty good. Decent range of motion and no pain, no discomfort. I now have poked on the person. I've done what I'm doing. I'm now going to start muscle testing them for two main reasons. I want to know, are they neurologically and structurally sound? And I want to know, do their muscles tell me more about their body than they're leading on? Because in conventional, traditional, applied kinesiology, there are organ-muscle associations, which means if I test somebody's quad, rectus femoris, can you hold your leg right there for me? And press up to the sky. And it goes weak. Try that again like you really mean it.
No, I do really mean it.
She really means it, and that doesn't work. So I just had new data about this person who I've never met, never evaluated or anything, but I just identified a hypotonic muscle that says, whoa, I should probably figure out what's going on in her. Is this muscle not working and not stabilizing, causing her to have low back pain? Maybe. Is this muscle weak because she's got a disc-related injury that I need to now support somehow? Maybe. Is this muscle weak because her small intestines suck and she doesn't digest her food and it's sucking up all the neurologic juice she has and now she can't walk and chew gum at the same time? Maybe. Is it a pain thing because she's got a dislocation down here in the hip? Am I grabbing a wound on her leg when I'm testing her? I have no idea what just happened, but it appeared to be hypotonic and I want to know why. Especially if I have a better clinical picture about why she might come to see me, right? Let's try another one just to see what happens. Leg straight. Your leg is straight. You're going to use this muscle, push up to the sky. Whoa. Okay. She's not paralyzed because she got a left leg that works and a right leg that doesn't. So that's good. We've at least got some level of lower spinal cord activity. And she walked up here, so that was good. So we rolled out a couple of things. Just to begin with, we're rolling out some stuff, right? But this leg right here, push up, does not seem to work. And I'm not cranking on it. I'm asking her to hold. I meet her pressure. And I give just a smidge more, and that worked out pretty well. So now I've identified a hypotonic on this side, her right side, and her left side is either normotonic or hypertonic, I don't know. But if I'm going to try and use her body to give me more information, whether it's regarding nutrition or neurology or chiropractic or acupuncture or whatever, and I'm going to use her body as a tool to give me data, I hope I'm getting good data from her and I'm not using bad data. Make sense? So therefore, we got this muscle here that's strong. That's normo or hypertonic, because we don't use strong and weak, because that's a weird word. And that appears to be strong, which means either hyperfacilitated or normal facilitated. I now have to figure out, is it really giving me good data? And so this is a concept called autogenic inhibition. Just like when I hit her knee and she kicks, I can do something neurologically to her body and get feedback to know if that muscle's working properly. What I'm going to do is aggressively approximate the muscle spindle cells of her muscle belly. Okay? Why? Let's think about what a deep tendon reflex does. Drop your leg down there. If I hit her tendon and I create a quick stretch of the muscle, her Golgi tendon organs and her muscle spindle cells say, I don't like that. And they contract involuntarily. And she kicks. So if I create aggressive contractionability, her body should say, I don't like that, and temporarily inhibit or go weak. Can we see why that might happen? Leg up here, leg straight, push. That appears to work well. Relax. I'm going to jab on you. Push up. It goes weak. That is a normotonic muscle. Who cares, Chase? I just want to sell her some AF beta food. Well, maybe I can still. Maybe I can give her AF beta food after all. But what it's telling me though is that this is giving me good data. So if I were attempting to use muscle testing of some way, shape, or form to get more data from her body, I'm so much better off using this muscle than this one. Because this one doesn't know what's going on in its life. And so when we ask her to push up, legs straight for me again, and press up to the sky, and it doesn't work, what might you do to make this work better? What's a thought? Give me a thought. You might stretch it. So what would you stretch? Like stretch her quad. So I could potentially stretch her like this and just kind of gently do that. That doesn't hurt anything? No. All right, we stretch it for just a little bit. Let's see what happens. Push up. Didn't make a change though. That's a great thought though, because I think that's one way of doing it. We could slide her to the edge. If this table wasn't rickety, I'd slide her to the edge and kind of maybe stretch like a hip flexor type of stretch thing. Could do that way. I tried bending the knee to drag that quad over the knee and stretch it that way. But that's okay. What's something else we could do? Origin insertion. It's like if I knew the muscle bellies, I might jab on certain body parts, like where it comes from the ASIS, or where it comes down here to the tendon, and just irritate the snot out of them. And a lot of times people are like, oh, that hurts. I'm like, I know, it's AK, it's not supposed to hurt. And then I just do things, and then we try it again, and let's see what happens. Push up. But it didn't work this time. If I do approximation, it would probably make it weaker, because that's what this did, right? But let's try it, because I like good ideas. Push up. Like down here.
More around than just.
Oh, here. Push up. No, not yet. Is it hurting?
No.
No, it's just weird, right? It doesn't work. Because I like selling F beta food, I'm going to try F beta food.
Okay.
Where'd my F beta food go? Middle, back. Who knows? Someone should have put these in order, I thought. I'm just joking. I know we put them in order, but everybody had fun with them. AF beta food. Got it. Whew. Crisis averted. This is one of my favorites. I like it. You can have one. I'll have a few. We'll have a good time together. All right. They're great. You chew them up. They taste kind of sweet. They're great. You got it? You can taste it?
Yeah.
Push up for me. Oh, dang it. In front of everybody, too. Didn't work. Want to spit that out?
I guess.
All right. Because we're doing nutritionally based things, I'm going to look at nutritional based solutions for now. I might roll her off. I wouldn't actually in the first visit. But what if I just cracked her back? What if she's got like an L2 that's misaligned and that's causing her quad to not work? And all I just need to do is put that bad boy in place, and all of a sudden the quad works. So we definitely can do structural things to the area. We can do structural things from the back. We could, laser it. I could massage it. I could needle her if I did acupuncture. I could do all kinds of stuff. And this is the great thing about being the clinician, is you get to decide what you want to do with people. I don't try to make permanent changes until I have a lot of details first. So whenever we find this muscle not work, I like to figure out if I can get a nutritional response before I make a change that might mess up my test. So we're going to try another one. I need a purple bottle. It's this one. SP Children's Immune. How many of you thought I should give that to her because she has a quad weakness? Anybody? No? If I tell you the quadriceps and the small intestines correlate through traditional applied kinesiology organ muscle associations, does this plausibly make sense now? It's a plausibility, right? SP Children's Immune. Push up for me. Oh, it didn't work either. Let's try it again. This is the cool thing about it, is we have no idea what's going to work. Someone said Biofilm Pro Balance, and I love that idea. That's a brand new bottle. Let's see. The bottle's open. Boring, boring, boring. I haven't found it yet, but Enzicor showed up first on my list, so we'll just try that. Why Enzicor? What? Some type of digestive enzyme. Maybe she doesn't digest things at all, and maybe it's irritating connections downstream. Ooh, doggy.
Whoa.
Was that cool? Wait, say that again. They didn't hear you in the back. What did you say?
Whoa.
Whoa, but why? It's just a quad that doesn't work. Why would Enzicor fix it? I'm sorry. Why would Enzicor facilitate that muscle that was imbalanced? Right? So what we've done here is we're now getting data from somebody by letting me do a physical exam in a slightly different way. Do you have hip pain? Do you have back pain at all?
A little bit back.
Was, what if the patient presents with both sides hypotonic? Well, keep in mind, this is demoing right now what we're experiencing. We're just learning how to muscle test, so we happen to pick a quadriceps muscle. If the muscle was weak on both sides, and you know the patient history, and you know what's going on in their life, that might be clinically relevant to you at that time. For today's purposes, it's an experiment. How do we get them to go strong again? Well, we talked about we could potentially adjust them, we could give them nutrition, we could do acupuncture on them, we could have them exercise or stretch, we could hum, we could do all kinds of weird things. So we do something to try and see if we can get that to go strong, because it's a diagnostic window that we're looking at the body with. Okay? It's not definitive of paralysis or small intestine obstruction or SIBO or anything else we might want to throw at it. It only tells us that that nerve is having a hard time communicating to that body part. Doctor, put on your thinking cap, let's figure out why. That's all it's really telling us at that moment. Now, if they were hypo and I wanted to continue muscle testing something in their body, all that really tells me is don't use those muscles, because that's a bad indicator. If I'm going to now start testing them to foods they're reactive to or using energetic vials against them or doing something, I can't use those as my indications of adequate reliability. Okay? Now the inverse of that happened. What if my patient had hypertonic on both of those? My brain clicks in and says, go check other muscles. Maybe their arm works, and I just have to know that for them I should use their arm until I can resolve whatever else is going on in their world to get the rest of them to be neurologically intact. Okay? Because I do diagnostic muscle testing on everybody all the time, whether they're here for just a back problem, or they're here because they are diabetic, or they're here because they have hormonal issues, it doesn't matter to me. I'm muscle testing the snot out of people all day, right? So I'm constantly bouncing in and out to make sure that I'm getting good feedback from the muscles I'm using, and I will test a glute medius, and I will check to make sure that it does what I want it to do, and if it doesn't, I just can't use that muscle today. I got to use other muscles to figure out what's going on, and I need to figure out why that's not working, and my brain's just doing that throughout the visit. Okay? From a standpoint of getting started, we picked a simple muscle to test that has fairly reproducible associations between multiple people on day one. Doing a subscapularis test is horrendous because it's so hard to access and do properly that if we've never muscle tested before, trying to figure out if a subscap works appropriately is really hard. So we picked an easy muscle, like the quad, right? So therefore, we don't know what happened yet. We only know how to identify, does the muscle do what we anticipate it should do versus not do what it's supposed to do. And the reason we did that is to figure out how we could incorporate some level of manual muscle testing diagnostic evaluation with our visit to add to the heart sound recorder, the laboratory test, the patient symptom survey, the whatever, to give me good data. Because if I have a patient that says, you know what, I have poor sleep at night, I don't feel like I'm rested and recovered, I'm stressed out of my gourd, and I'm systemically hypertonic, they won't say those words to you, but their manual muscle testing will tell you that, then you now know that someone's fight or flight system needs to be significantly overhauled, and you need to drive parasympathetic tone in their life by supporting their adrenals, balancing out their brainstem, calming down their nervous system, whatever. But if I don't do the physical exam to find systemic hypertonicity, I don't know that about them. I'm now just relying on their symptom survey to tell me what to do to them. And so I'll give them something like Nevaton, and that might be appropriate. And I might give them min checks, because that's appropriate. And I might give them organically bound minerals, and that's fine. But what if Enzicor fixed the problem, and I never once tried something like that on them? It allows me to look at the body in a different way rather than symptomatically dosing out what I think they need based off of their perception of how they feel. Okay? So, can I borrow you for a second? A moment ago, we identified bilateral, both side hypertonicity in the workshop. And our job was to try and figure out, does it do its thing? And you'll notice here that it says when hypertonic muscles do not weaken, the muscle should be addressed before you continue using that muscle. Like, get it to work properly before you think it's telling you the truth. If you need to do that, you could do physical, chemical, emotional, or some other thing that you might find relevant in your clinical experience to get it to change. And it might be something as simple as, I just need to adjust the patient before I start using them for a nutritional evaluation. And you adjust them. And now all of a sudden their muscles tell you what you need to do, and that works. It might be that you need to acupuncture someone in some place, and then their body tells you what you need to tell them. But it might be something else. So we're going to evaluate other muscles and figure out what might happen, because all we know so far is that her rectus femoris doesn't work right. Hypertonic. I will quickly run through some of these slides, but I know we're kind of not wanting to spend we're not going to spend the most of our time seeing each of these. I'm just going to demonstrate them. There will be a somewhat decent picture from a 1970s textbook showing you what to do, and then we can kind of go from there. Okay? So, if this is from the traditional AK textbook, and they're ghetto pictures, but they work. Talks about origins and insertions. Talks about where the nerve's coming from. I'm going to skip through a bunch of these real fast, because I'm going to show you this chart here. Muscles have a strong association with organs due to their nerve associations. And we went over this a minute ago, right? We talked about how when you have a heart attack, you feel it in a specific spot because the viscerosomatic reflex tells you it's a neurologically driven mechanism. So therefore, when we start using muscles as diagnostic tools for the body, we can extrapolate data to other body parts sometimes, right? Because if I have a quad that's not telling me good information, and I come down and I find the rectus femoris, oh, that's all I'm done with this, sorry, rectus femoris, and it tells me possibly small intestines because this nerve tells that what to do and this nerve tells that what to do, I know more about the person that I'm evaluating. And maybe I just need to crack their back. I'm a bone cracker. I can move some things. I'm good at it. And that could be the best thing that they need to get their problem solved. But maybe they've got something else going on. And if I hyper-focus and put on my chiropractic hat and ignore everything else in their world, I might not get them where they want to be. So I'm just Dr. 43 on their list as they're on their health journey getting better. They're like, I tried chiropractic, it didn't work. I went to Dr. Chase, and it didn't help. Because all I did was say, your back bothers you. Let me just crack your back. Right? So I'm going to test a couple of other muscles on her. And you can see the muscle list here. And we're talking about organ-muscle relationships for low back and digestive-y things. That's why these were pulled out. You could do this concept of normotonic, hypertonic, hypotonic with every muscle in the body because it's a neurologic reflex. We'll go to tensor fascia lata. Leg is straight. I rotate it in. I slide it out about 15 or so degrees, and I'm going to have you push up and out to the outside. Go ahead. That appears to be a good, strong muscle. I'm not trying to overpower her. She's not trying to be overpowering. We're going to test it again. Push up and out to the outside corner. Those both appear to work properly. I'm going to pull out my magic nerve activating digits. Push up and out. Sorry, I think we were out of sync there. Push up and out. Try it again like you really mean it. There it goes. It took like 2 or 3 times for it to come back. Push out. So that works. She's good and strong. I ask it to go weak. Her body says, I don't even know what's going on in my life. Push up and out, because she just shuts down and it just goes weak. And it's just one of these things that's not working. Push up and out. And normally we just get like 1 test, but she gets like 3 tests before her body recalibrates, push up and out, and says, now I can function again. Normotonic muscle. So it's not systemic anymore. It's just these two. Let me ask this other side here. Push up and out. That goes weak. Good. Push up and out. There we go. Push up and out. So we got good, strong muscles. I ask it to go weak. Push up and out. And it shuts down. Do you feel that? Weird, right? Cool. What does that tell us? Nothing. Other than that's a normotonic muscle. The rectus femoris, hypertonic muscles. If I'm looking at potential associations between neurologic involvement to the muscle that's not working properly, I might think possibly small intestine related stuff. We already jabbed on her. It didn't hurt when I pushed on her belly. But I'm trying to get her body to do what it wants to do and what it's designed to do. So just grab some stuff. Like, I don't think we have chlorophyll up here. Anybody seen a chlorophyll when they came up here? No? All right, Enzicor. Okay. Fingering. Let's try a GI Adsorb. Oh, we got Zymex 2. Zymex 2 is not on our list up there. Does anybody know what Zymex 2 does? Anybody ever use Zymex 2? If I tell you the ingredients are defatted almond, date powder, papain, bromelain, organic pineapple fruit powder, amylase, cellulase, and lipase. Do you have an idea of what Zymex 2 might do now? Bunch of enzymes, helps the intestines do things. I don't know why it's not on my list, because it's a good product. Let me borrow this. There we go. You can put that in your mouth for me. That date powder and the defatted almond and stuff, some people will use this as a mild antiparasitic. So it does some good stuff, right? So we just put it in her mouth. We're going to test to see if it makes her hypertonic muscle work better. Push up for me. Push up. There we go. That's good and strong. Now push up. Doesn't work. All right. You're a lost cause. No. All right, so no Zymex 2. What's something else we could try? If you start throwing out stuff, I'll see if it comes across it before I find the next one I want to try. Lactic acid yeast. Anybody ever used lactic acid yeast before? What does lactic acid yeast do? What's in it, more or less?
Acidify the colon.
Acidify the colon. Why would we do colon-related things? I'm thinking if you walk like a duck and talk like a duck and swim like a duck, you're probably a duck. And so when muscles aren't working properly that share the nerve supply with other ducks, I want to try and get it squared away, right? So we're going to try some digestive-y things till we figure it out. Put that in your mouth for me. So once again, it's got, digestive-y things that change the gut. Press up for me. Good and strong. Press up. Nope. You might just need to have your back cracked. No, we can't do that. I'm sorry, what are y'all saying? What are some other things? You're playing doctor right now. She's on your table and she's frustrating the snot out of you in front of all your closest friends. So, what would you do? Digestive stability, so GI stability. If that's up here, we could grab it. What else? I still haven't found biofilm pro balance. Cataplex AC. Let's see if that's up here. This one here is Digest Forte. Do y'all say Fort or Forte?
I have this every day.
I say Forte because that's normal. Some people say Fort, which is weird to me. But they also say tinnitus instead of tinnitus like they're supposed to. Push up for me. So that's good and strong. Now press up. Doesn't make that work better. Is it possible this isn't really a digestive thing after all? Maybe. That's weird though. What else? What else? What else? What else? Did we try Enzicor with you already? All right, we're going off label. Anytime you just feel like you're stuck with someone, what's the number one thing you like to grab? When in doubt, conjuplex it out. So I would do that if it was like more immune driven, and definitely you can do that. So when in doubt, conjuplex it out. That's a thing to just live by, right? What's something else you might do if you ever just were like, man, I am stuck and I have no idea why this isn't working right? Push up. You like Zypan for digestive stuff? Thymex for immune stuff. I love that kind of concept. Push up here for me. I went ahead and picked the right answer though. Relax. Push up. Good. Do you know what my answer is? Push up. Cataplex B core. Because if I have somebody that's overstimulated, hyperfacilitated, their nervous system is doing this somewhere, I don't mind calming it down with some B core. Cataplex B core. That's what we tried. And push up.
I have that too in the morning.
That's okay. You might just need to triple your dose. Push up. Push up for me. Good. How much cataplex B core do you do?
Every day.
Relax. Now push up. Push up. Yeah. Cataplex B core.
Wow, I have it every day.
Well, no, we're just gonna give you. Do you want to spit it out or keep it? You can have it. Perfect. So that's a good question. You know, why would she present this way if she takes this supplement already? It could be a dosing issue. It could be a stressed out issue. You know, maybe she had to drive across town. Maybe I'm not as funny as I think I am. Whatever it might be, right? Like maybe it's stressed out being in front of people. I don't know. But that thing was not working properly, and we tried a bunch of our normal thing, our go-tos, and it wasn't working. So we had to brainstorm amongst each other.
So you just
Maybe it was
gut
thymic.
and just went.
Yeah, I just knew it was a gut thing because it was a quad thing. But it didn't hurt when I jabbed on her, so maybe I should have gone back to my normal physical exam. Maybe I should have had a little bit more history about her, because I spent so much time dealing with gut stuff for a muscle that wasn't working, when really if I just calmed her nervous system down a smidge, that's what seemed to have done it. Okay? So it's an interesting thing to experiment in real time, because I'm surprised, because I don't know what's going to happen. I'm sorry?
The HSR might have pointed.
Yeah, exactly. I could have had another data point that said, wait a second, you know, you have these weird ratios of your heart sounds, or you have these weird whatever, and I may have already looked into that concept. So this is a guide to get us started, but you as the clinician know so much that we don't want to just like be so pigeonholed into a one answer solution every time. Oh, quad didn't work. Must be small intestines, therefore must be Inzicore. Next. Well, maybe, except when it doesn't. And that was so glad that you made it so difficult for me up here, because it gave us a chance to just brainstorm and talk about what are the things you do in your clinic when you're stuck. We conjuplex things out. We thymex it out. We, whatever, someone said simplex it out. We RNA it out. Well, I like cataplex B core. I like Drenamin sometimes when people just, you know, when I just don't feel like I'm getting the right response with muscle testing, I'm like, that's weird. You shouldn't test this way. You should be appropriately strong. I should appropriately turn you weak. You should appropriately do the reflex you need to. And if you don't, it makes me think your nervous system's jacked up or you're adrenally stressed out. So therefore, I might try Drenamin or adrenal complex or cataplex B core or something like that to just say, you know what, maybe if I just calm your nervous system down, you'll be more receptive to this give and take of the physical exam I'm going through. So, cataplex B core, I have a hard time not trying that whenever I'm feeling like I'm floundering, because it's a good thing that just is all-encompassing for calming down people's hyperactive activities. Even though we just knew it was going to be the quadriceps and knew it was going to be small intestines until it wasn't. Right? So, if I can borrow Liz, come on up here. I probably muscle test you more than anyone else in this room. I'm going to demonstrate just these other muscles so we can focus on the ones that deal with digestion things in conjunction with like symptomatic low back things. Now, why low back if we're doing a quad? This is the front of the body, not the low back. Well, if this muscle isn't working properly, there's a greater tendency for backs to not work right. Or if backs aren't working right and things are pinching on other things, there's a greater tendency for this to not test appropriately. Okay? So I'm going to quickly run through the ones that are face up, then we'll flip her over into the ones that are face down, and then we'll just see where we go from there. And if you have questions, I'll re-demonstrate some of the muscles. So we already saw quadriceps or rectus femoris, so I'll skip that one. Tensor fasciae lata, I roll the leg in, I give it a little bit of an outside up and out angle, pushing out and push out, and she tests there. And once again, I'm not going for muscle strength like we're bench pressing. I'm establishing a lock with the muscle. I come over, I jab the muscle fiber together. I ask it if it's willing to go weak. It says it is. It's a normal tonic muscle. I can go on to the next one. For a piriformis muscle, we'll do a supine piriformis muscle. She bends her knee, relax for me, bends her knee, and rotates it all the way in, and she keeps her leg there. I stabilize on the outside, and I just rotate her leg out. Hold it there, push your foot that way, and hold. Really good. How am I going to muscle spindle cell down the piriformis? I'm going to jab on her butt. I'm going to say, I'm going to touch her butt. And I come under here, relax your leg, and I pinch. And I test it again. And it seems to go weak. Does that make sense? We find a muscle, we ask if it tells us the truth, we retest the muscle. All right, we did performance psoas, leg straight, turn the leg to the outside. We're gonna push straight up, and that's strong. It's really hard to muscle spindle cell psoas because there's about 4 inches of stuff in the way. So what do? We try another muscle, or we do something different. We're gonna hold off on what to do next because I can't really muscle spindle cell that down. It's too hard. It's the best part of a deer. It's on the spine. It attaches to her spine on the back. There's no way I can get to that muscle belly and jab into it. It's too much stuff in the way. So I have to go to another muscle. Iliacus, we're gonna do the same style of test as the psoas. So we just rotate her leg out, but now we bring the leg out with us, and she's gonna push up, and we're gonna do the same thing. I can't really jab into that because all of us have bellies. It's all under there, attached to the back of the wall. So I got what appears to be a strong muscle, but I don't have a way to know if it's normotonic or hypertonic at this point for those 2 muscles. Quadratus lumborum, those are gonna be low back muscles here. Grab the table with both hands. Take both of your legs and slide them that way. Reach under her legs, get a good biomechanic position. Push your feet that way and hold. Uh-oh, who's your doctor? Try that again, push that way.
It's not Monday.
Huh, you need to get and see him Monday morning, 7:40. Push your feet toward me. She has a stand-in appointment in my office on Monday morning at 7:40. Push both of your legs that way. Yeah, quadratus lumborum muscles do not appear to facilitate the way they're supposed to. I almost said weak there, right? They're neurologically hypotonic. That tells me something. Do you have gut problems? Low back muscles, like the quadratus lumborum, often correlate with gut-related stuff. And if you were her doctor, you'd know she has celiac disease, that she can't even look at gluten across the hall without reacting to it. You know, she has all kinds of reactions with gut stuff. And so it makes clinical sense to have quadratus lumborum muscles that don't work. Is your back bothering you? Yeah. That's weird. So things like that are happening, right? Abdominal muscles, sit up for me. Legs, facing that way. Give yourself a big hug. Lean back just a touch. Stabilize, push a knee. Great. That's a way to check abdominals, right? Those are the ones you can do face up. Flip on your belly for me. I know we're going semi-fast, but everybody's doing okay so far? Makes more or less clinical sense. Hamstring muscles. She bends her leg. I place my hand on the hamstring so she tries not to cramp. I push her away. Good. And again. Good. Now, is her hamstring stronger than my little triceps? Yes. We're not leg curling here. We're not working out. I'm asking her to hold it and give me some pressure, and I'm matching that pressure and giving just a touch more. If she wants to pretend she's a bodybuilder, I'll attempt to try and counteract that by stabilizing and doing a whole lot more, but then we're both tired and it's no fun at night.
Is that another good choice to see
I'm sorry?
if it goes weak?
Yeah, this is a great one to do, see if it goes weak. So it appeared to be fine. I can jab it together. Now push. Whew. Went weak like we wanted it to. Push. So good and strong. Because I'm matching her pressure and giving just a little bit more. So those are going like we want them to. So that's great. Glute maximus is easier to test while laying down. Lift your leg up. Keep your knee bent. Press. Good and strong. Bend your knee, lift up, and hold. She's a really good person to test for hyper and hypotonic stuff because she just falls away whenever it goes down. That's why I picked her as my guinea pig. That's why you'll never be my guinea pig again. No, I'm just joking. So, does that make sense? So we did all of them, rectus, quad. Perfect. Does anybody need me to demonstrate another one before we play around? Okay, go on your back for me. We're gonna introduce a new concept, which is on a later slide that we're doing right now anyways though, because I want you to play with it before we end on not doing it. Iliacus, sure. This is exactly the muscle I want to use. She stands up, or legs straight. I roll it to the outside, and I just A-B duct it a bunch to about here. I stabilize so it doesn't feel like I'm pushing her off the table. Like push up, push up. This is just weird. It's hard for people to do. But if I can give her something to brace against, now push up, then it works better for him. But we already talked about not being able to muscle spindle something down. We talked about different types of muscle testing. Boring, boring, boring. All right, here we go. We're introducing a new idea real quick. You can use magnets to do the same thing that jabbing on people does. And that sounds really, really weird. Some of you are awestruck, I can tell. But we just saw a second ago that if I took a muscle, push up, and it's good and strong, and I ask it to go weak, it goes weak. That's normal, normotonic. This is an example of a magnet, a large magnet that I use in my office. The N stands for north, the south stands for not north, okay? The north pole of a magnet, when placed over the muscle you're testing, will cause it to autogenically inhibit without me having to jab on them. Push up. We've got a good, strong muscle. I pull out the north pole of my magnet and place it on her, and I test her again, and I should get weakness as a normal physiologic response to the stress of the muscle spindle cells and the electromagnetic field they generate. And that's a neat trick because it allows me to muscle test without bruising people, and it allows me to test muscles like the iliacus, push up, to see how it goes, and the psoas to see how it goes, and the pec minor without having to jab in her chest to see how things are going. And I can use a magnet to be less frisky when I'm doing piriformis testing. Hold that right there and push. And I don't have to jab on sensitive areas anymore of delicate flowers in my office, right? So I want y'all to practice. And I brought a whole bunch of magnets that I have in my office that are in all my treatment rooms and everything. Yeah. The white dot stands for north. The not dot is south, which is not north for other people. Okay? So when you test people, you can just grab one of these magnets. Please don't smash your fingers. They have like 30 pounds of draw, and they hurt when they pinch you between your fingers.
I know.
Push up for me. So she's good and strong. North pole of a magnet. Ask her to go weak. She goes weak. Test a variety of muscles that you now know how to test, or that you already knew that were just refreshing. See if they go weak appropriately. If they don't go weak appropriately, try muscle spindle celling them to see if the tests are different. We're playing around right now, seeing how your diagnostic criteria is as you're looking at people. And it's going to be a new experience for a lot of us because not everybody muscle tests other things in the body. Some of us may muscle test this, and if you want to try that, that's fine. It's a little bit different because when you do this, which muscle am I testing? It's debatable. Most of us think anterior delt, but this is a non-traditional muscle test, and so there's an accumulation of muscles that we might be recruiting and doing. This is why the International Applied Kinesiology, like the International College of Applied Kinesiology, discourages this test, and it's not standardized diagnostic muscle testing according to their viewpoint, because it's a hard thing to isolate and say, what am I really doing here? Now, it definitely works. We all do it, or many of us do this in practice and things. And so I don't want to discourage the use of this necessarily. But if you do something and you're like, okay, and you stick your magnet close to them and it doesn't give you the result, she gives me the result I want when I go to anterior deltoid. But if it doesn't give you the result you're looking for, it might be that she's compensating somewhere, and we might just need a better version of a test to where I can maybe come check deltoid, middle deltoid, and challenge it. Say, okay. And then come over here, anterior deltoid, push up in that way. Oh, doggy. So that one's a weird one. So we could isolate other muscles if we knew how to muscle test other things, but this sometimes gets people into trouble when they're first starting muscle testing because it's a little bit of an inconsistent, because sometimes we're here, sometimes we're here, sometimes we're here, and people struggle with keeping the test accurate. So we're today demonstrating diagnostic muscle testing as taught by the International College of Applied Kinesiology to isolate the specific area we're looking for and limit compensatory muscle fiber activation. Does that kind of make sense? Keep us clean, that's right. All right, ready, break. Yes, sir.
I got a question. Have you tried this on like any folks with like metals in their bones or like
I have.
pacemakers, and does that throw off the reading?
The pacemaker tends to jack people up really bad whenever you put this really close to it. I would discourage that. So yeah, with pacemakers, it's part of my intake forms. I know, like, if you have a pacemaker, please tell someone so they don't stick this up to you and kill you. That's not going good for standard process if that happens. I ask people in my intake forms if they have like electronic devices. I've turned people's bladder pumps off on accident before because they didn't tell me. And so I was in there muscle testing someone and having a good time, and they called me 2 days later and they're like, I haven't peed since your visit. And I was like, really? That's so weird. And she's like, oh, wait a second, I've got a bladder pump. I wonder if you turned it off somehow. And I was like, I don't know. And I'm looking through her notes going like, oh, I hope I don't get sued. And it didn't have anything like that talked about bladder pumps in there or anything. But she was like, oh, it's no big deal. I just have to go to my doctor. They reset it real quick. But there's like lost Bluetooth connection or whatever she was doing with her device because I took some ginormous magnet and stuck it right up to her pelvis and just turned it off. So she didn't pee for 2 days, and that was awkward. But when people tell me that they have pacemakers, I just don't go close to that area. But I sometimes still test people.
If they have a pacemaker, I'd be scared to even.
Man, I'm like the Wild West. I don't care what we do in my office. We just see what happens. I'm like, oh, you got a pacemaker? Okay, well, tell me if I get too close. No, I still use some magnets with people in the office. I'm mostly doing it with muscles on the extremities. I'm doing it much less on the core of their body, though. But I've got a bunch of magnets. What other questions, if any, do y'all have? Is this weird? Have any of you ever tried using magnets to turn muscles off before? How many of you is a new idea? Like you've never heard of this before? Okay, good. Come play with it a little bit. Okay, I've got lots of magnets. Please don't jab your fingers. Come grab some. Ready, break. We're on a break. Or we're on a workshop. SP Children's Immune up at our front desk. And we write sample on the top of it because they taste like candy to me. And so mostly I just go around and munch on them throughout the day. But sometimes kids like testing them out and seeing what they like. So we tried SP Children's Immune a little bit earlier when someone had a potential gut thing. If you're ever just sitting around bored, this is a great product for just daily use. Helps support the microbiome, has some elderberry inside of it. One of the only products from Standard that has colostrum. So it's just a neat thing. And they taste good. So if you've never tried one, come eat one. I think they taste good. My 7-year-old will go through a bottle in about a week if you don't watch him, because he thinks they're really good. But good. Side tangent, because I saw them and I wanted to eat some. Did everybody have a chance to just play around with some muscles and see if those muscles changed in the presence of the magnet? Did anybody not find the muscle reaction that they were hoping to find while introducing the magnet?
On one muscle.
So you tested the muscle, you put the north pole of the magnet to that muscle, and it did not go weak like it was supposed to?
Correct.
What does that mean? Hypertonic. What does that mean now? That's right. It doesn't. It just means we got to figure out why that's not happening. Because maybe that section of the body is misfiring and not doing its job. And if that makes sense in the clinical picture, as you sit with the patient and you're opening up, trying to figure out what you can do to be in their best interest, you now have a data point that you didn't have before. I understand and completely know that this is overwhelming on day one. There's so much stuff to possibly talk about when it comes to muscles and joints and organ associations and nerves and nutritional support products and whatever. The purpose of this is to try and look at the patient a little bit differently. It's super easy for us to leave and go home to work on Monday morning and do the exact same thing that you've already done for the last X number of years that you've been successful with. We all do it. We come to a class, we get excited, we have a good time, we go home and say, it's Monday morning, I'll just do the same thing that I've been doing for 20 years. Okay? The purpose of this particular workshop is to look at the body a little bit differently and see how we are interacting with the patient and introduce a potential new way of seeing the person. So if you don't already palpate the person to begin with, maybe that's where I start on Monday morning. I say, you know what? I already do the heart sound recorder on every patient that comes in. I already run the omega quant on every person that comes in. I already do my symptom survey on every person that comes in. But today, we're going to do something just a little bit different, and maybe I'll get an insight into you that I didn't have before, so that I can be the clinician you need right now to achieve the level of health that you desire. And that's how I would take this workshop, hopefully, is be able to say, what is it different today that I didn't do before? Or the next time someone comes in with a gallbladder thing and you say, dang it, I've tried AF beta food, I've tried Col-Col, I've tried whatever. Let me try Antranex. Because I heard a clinician that had good results with that at one point, but now how do I know if they're going to improve with it? I could give it to them and say, here, try this for 30 days and see what works. Is that a bad option? No. It's better than no option, which is my gallbladder still doesn't work, and we've tried some good stuff, but it's not getting where I want it to be. So now we have another option, which is try it, which is great. Could we potentially do something different? Like, how? It hurts when I jab on your gallbladder, and you've been having gallbladder issues, and I've never jabbed on it before. That's neat. Let's see now if I can take something off my shelf that's better for you than general gallbladder support from what the clinical reference guide tells me. Right? So it just gives me a way to interact with that patient in a slightly different way. So now I jab on people. I've possibly think of these clinical pearls that we've shared a little bit throughout today. And maybe we've got someone who's got a stubborn back. They see you every Monday morning at 7:40 because their back always bothers them. And you're like, you know what? Let me just try something different. Let me try something different. And so you say, you know what? I went to this class this weekend. Are you okay if I just take 5 minutes and try something on you? And they're going to be like, yeah, whatever. And you just lay them down and you say, will you push up right here? And you just test some things. And you try a muscle spindle cell and it's hypertonic. And you're like, whoa, that's weird. I didn't know that you had hypertonicity to your quadriceps muscle. And that now gives me new data as I enter this clinical relationship with you. And maybe I've been cranking away on your back all day and that's not in your best interest. And maybe I need to address your gut. This is now just the wheels are turning as I'm interacting with this patient. And maybe I don't tell them this, but maybe in my mind that's what I'm thinking. Maybe I should try enzymes on this person. Maybe I need to change their diet. Maybe I need to get them off of an inflammatory food. Maybe I need to do something that I haven't done yet, but now it makes a clinical rationale because I tried testing their rectus femoris for their hypertonic low back that's always bothering them, and I'm finding there's other parts of the body that are always stiff and tight also, and maybe their gut's referring the pain to their back in a viscerosomatic way, and I can now look at them in a different way. Okay? Does any of this seem too crazy? Do you see the potential neurologic rationale between tasting something on your tongue, poking on the body, muscle testing and seeing if the reflexes are working appropriately? Does that make relatively plausible sense? Okay? Because we're about to do crazy stuff now. Everything has been moderately normal up to this point. So, the magnet was the new weird thing that we just messed with. And we saw that a magnet reflex causes a localized change whenever I test the muscle and put the north pole of the magnet over the localized muscle that I test. Ashley, can I borrow you for a second? Can you have a seat right here? Ashley and I have a great relationship. She spent some time in my office hanging out, and we became really good friends. And now I'm so excited for her new office. You know, she should have stayed with me instead. But she's so great. She's a phenomenal clinician. I'm so glad she's in our world together. We are going to test, I don't know why I have you sit down. Will you lay down on your back here? We're going to test her rectus femoris. And we're going to introduce an idea. Push up for me. When we test her muscle, and it appears to be strong, we can now ask it and ask if it's appropriately strong or not, or if it's hypertonic, and she appears to go weak when I put the challenge on her, so we have a normotonic muscle. We think that's looking good. That's a local challenge to a local area, local information. But maybe I would like some systemic information around this person. Does anybody know where the solar plexus is? Kind of in this-ish area. It's kind of like, give or take, small intestine area if you wanted to be hyper-focused. So in different energetic systems. Now remember, we're branching out of the world of foundational neurology, and we're moving into this like delicate balance of intention, energetics, maybe Chinese medicine, maybe something that's a little bit harder to pinpoint through a blood test or through an anatomy chart with spinal tracts and stuff. If I take this north pole of the magnet and place it around the solar plexus area and then retest her, push up, I should get global weakness. because her energetic system says, I'm not a fan of what you're doing to me right now. And it's stressed out, and it's sending all of the energetic juice to this area to try and fight off whatever I was doing. And it compensated by shutting down and down-regulating other areas appropriately. And I took that magnet away, and her body says, thank you. I can go back to testing normally again. And I can test, we didn't go over some of these muscles, but I can just re-challenge some stuff on her and make sure that systemically she's appearing to test like we want her to. And then I ask her, how do you handle stress? And her body says, very appropriately. And you're like, wait a second, she's going weak though. How is that an appropriate test? We would call this a normotonic response to a stressful provocation. Does that make sense, or was that weird? I know it was weird, but did it make sense at least?
Was it the North Pole?
It was the North Pole. The North Pole is our stress side, kind of. In this scenario, the North Pole is the right answer. The North Pole makes things go weak on purpose. So locally, I can do this. Now watch what happens. If I take this North Pole of the magnet on her quad, we expect this quadricep muscle to go weak. Good. What do we expect this quadriceps muscle to do? Push up. Stay strong. What do we expect this pec major clavicular test to do? Strong. Because it's localized stressor. If I move it to systemic portion of the body, we would expect her body to weaken systemically. This is a way for me to evaluate if her nervous system and her energetic system are doing the things I expect them to do.
Can you use that for observable testing?
You can use this for all kinds of things. If you're creative enough to figure out how to test it, it can be tested. And I don't mean that facetiously. But let's imagine that I wanted to put red sunglasses on her, because maybe I like to have people look through red glasses. And I could then challenge her body and say, how do you do with red glasses when you're looking through them? And I could say, hey, oh, that was strong. We're just imagining she's got red sunglasses on. Oh, that's strong. And then I put this on her, and then I test it, and hypothetically she's super strong with the new change that I did to her. That would indicate to me that that new change is probably jacking things up, and I need to figure out why that's happening. Because I broke her. I'm inducing something that's messing up our normal response, right? Let's think of a completely different scenario. She has her leg off the table, and I hit it, and it gives a normal reflex. And I put red sunglasses on her, and I hit it, and she twitches for 5 minutes. Would you think that's a good idea? No, because we just jacked her nervous system up, right? So I'm doing the similar concept, but testing with the magnet and with the muscle. And so I use diagnostic muscle testing and magnets with every patient all the time to make sure that whatever I do is not inducing a problem. And that's weird to think of. And I'm not saying that I'm the right way to do it, even though it is. I'm not saying that, but I'm insinuating it. No, I'm just joking. I do the things I do because it makes sense in my brain. And that's why none of you are Chase Hayden. You have to practice the way that you practice. And so hopefully you'll see something and you'll say, you know what? I think that could fit the model in which I view the world. And I can incorporate this here. So when I'm challenging stuff in people, and now let's pretend, hypothetically, I'm got her on a nutritional program, and we're not going to pretend that. Let's pretend that I just adjusted her back and did whatever I wanted to do with her, and I'm going to say, good luck, you're on your own. I might challenge to make sure that whatever I did was not too stimulatory to her nervous system, that maybe I don't need to warn her like, hey, I might have overdone it. Why don't you not go to the gym today? Because at the end of my visit, you are in a hypertonic state. Ugh. I may have just overstimulated her a little bit more. Like the first time I had an MS patient come to see me, I thought I was going to fix her in one visit. So I spent 90 minutes in that visit because I had nothing else to do. I was like, great, you're like my third patient I've ever seen. And you walked in on a cane and you have MS and someone said I could help you? Sure. And we had time, I had nothing else to do. I was broke and didn't see patients. So I just, 90 minutes later, she's like, man, I feel really, really good. I was like, you should. We just fixed a whole lot of stuff in your nervous system. And for 3 days, she couldn't walk after that. And so I overstimulated her body, and her nervous system said, this is great, but I'm going to crash now. And she just couldn't function. And so it started helping me to figure out how I might judge if I'm doing too much with someone who's neurologically compromised, or if I'm doing too much nutritionally with someone. If it's shutting down stuff, it's a potential problem. So let's take this pill that I've never tested her on. We take this and place that in your mouth for me. She has a new stimulus added to her life. Push up for me. She was strong earlier. I asked her to go weak. Push up. She didn't go weak. Push up. She's good and strong. Push up. She doesn't go weak. North pole of a magnet, push up. Doesn't go weak. Push up. Doesn't go weak. That was a good first guess. You're a better demo than, no, I'm just joking. Push that way. All right. Based off of your potential worldview of looking at someone, would you give her that thing for her to take home and start taking all the time? Why not? It's a standard process supplement. It's awesome. It's going to help with blood sugar. It's going to help with immune system. Not for her. Not right now. Not this time. Not this dosage, right?
What is it you gave?
I don't ever want to throw a product under the bus. No, I'm just joking. It was Diaplex. So I don't know if you ever needed Diaplex in your life before, but it would just happen to be the first one I grabbed. So now, we took it out of her life. I can now come back and just ask some questions again. Push up. Good deal. We're back to testing again. I can now tailor specific my nutritional program to her specific neurologic needs at this particular moment in time. And I can have a check and balance to make sure that even though I think I know what I'm doing, her body is okay with it. And this concept will prevent you from selling more supplements. And I hate to say it, but it helps the patient have fewer reactions. I mean, I love to say that it helps with fewer reactions, but I hate to say that you may not sell as many supplements as a result of it. Because it's super easy when someone walks in and says, I've got diabetes, and you say, here's my diabetes protocol. Take these 8 things, we'll see you in 6 months when we redo your blood work. And that's a way of doing it. But what if I challenge her specific interactions to these products, and 6 out of those 8 test well, but the other 2 don't test so well? I have done for her a better service by matching the program uniquely to her needs right this moment. And I'm much more likely to have fewer side effects, fewer phone calls over the weekend, and a better patient response. Because now her nervous system is congruent with the program that I'm recommending. Yes, ma'am.
So, in one of the previous slides, it was saying that if they're all the muscles are hypertonic, then there's something going on neurologically.
Yes, ma'am.
You said deal with that first.
Yes, ma'am.
So, can you help me process that? Because if someone came in and they're neurologically impaired and they're
Hypertonic, right?
then this wouldn't work with them.
Maybe, maybe not. And that's a great question, because there's a scale of neurologic jacked upness. Okay, so Ashley is a neurotypical person. She can walk and move and do things, and if she has a hypertonicity issue, she's probably hyper responsive to something that I do. And if someone, like we were talking about that patient earlier, that with cerebral palsy, she's always hypertonic, like everywhere. She's clonus, she can't talk, she can't move, she can't walk. I can't do some of these things on her because of the level of hypertonicity and neurologic dysfunction that she has. I was like, that's crazy. You have diabetic neuropathy. You shouldn't react this fast. And he's like, I don't know what you did, but that 100% feels like the other side. And he's sucking on this thing, and it's like, well, if you were the doctor, what would you do? And he's like, I want to take that. I was like, I want to sell it to you. So I gave it to him, right? So that process creates an afferent change. Now, does he still have diabetes? Of course he does. Does he still have neurologic damage to the area? Of course he does. But if I can change the afferent system, his thalamus says, there's something new going on in my world. I might be a different person now. And he developed improved perceptive activity to his dermatomes, right? So what I like to do in the way that I see my world is challenge people to things before I give it to them, even if I think I have a good clinical rationale and justification for giving them that thing. So when someone comes in and they're like, I get bloated and gassy and constipated, my back hurts, I want to lose 20 pounds, I'm hot, flashy, and hormonally, I think, okay, I got some stuff I'm going to mess with. I'm going to give you wild yam complex. I'm going to give you AF beta food. I'm going to give you Enzicor. I'm going to give you Simplex F. I'm going to give you these things. I'm thinking it already. And I start poking on them. And they're like, oh, wow, it hurts over here. And I'm like, okay, that product should help with your baseline symptoms that you came in with. But also, let's see if it helps you physical exam-wise today so that you walk out and say, hot dang, Chase knows what he's talking about. I had pain and now I don't. And then I muscle test some stuff and I find some things that aren't working like they need to. And I put that thing in their mouth and they muscle test better. And they're like, wow, that was neat. It was like magic. I'm like, I know, it's crazy. It's neurology. And they're just having such a good time. And then I might weed some things out and say, maybe I was going to put them on Simplex F and wild yam complex and AF beta food and neurogenics. But when I put neurogenics in their mouth, it didn't do what I thought it was going to do. So maybe that one comes out and instead I put Ulprima EPA DHA in instead. And then that makes the improvement I want. Because both of those are neuro anti-inflammatory. But now I can use the right neuro anti-inflammatory that this person asked for right now. And I can let her body tell me exactly what to do. And it takes the guesswork. It takes so much pressure off of me to not have to create just the perfect program. Because now I just do what her body tells me to. Hey, let's try this thing. Wow, it made your muscles go hypertonic. That was a terrible idea. No, it was a good idea, but terrible application. So therefore, I'm not going to give you Diaflex. Let's go to the next thing that makes clinical sense. Okay, we'll try AF beta food. Oh, cool, AF beta food does what you need to do. So let's go with that. Does that make sense? So systemically, I like this reflex of the north pole of a magnet over the belly to challenge a bunch of muscles at one time to tell me that systemically, she does what she's supposed to. Can I have you sit up facing that way? Now, you have any questions so far? I don't know if I really answered your question. That was a long tangent to answer your question, but did I get it there at some point? Okay. Yeah, so you just do the best you can with what we got. And sometimes what we do is more appropriate than other things, and we just learn about it as we're going. All right, like I said, at some point y'all will get all these slides. We talked about autogenic inhibition. We talked about oral nutrient testing. Therapy localization, we didn't talk about at all, so we'll just leave you in the dark there. No, she's joking. It sounds like what it is. You touch things to make it better. And earlier we asked what might happen if someone was weak and not getting better, and Ashley said, you just therapy localize it, because she's got a phenomenal mentors in her life, and she knew the right answer. Not me. JJ Greger, Christy, you know, all these awesome people in her life. They taught her these things. But therapy localization is just touching with your fingers over the spot that might correlate. So lie on your back for me, and I'll show you just a little bit what I mean, possibly. Perfect. Let's use one of these pictures. I realized how behind I was about 20 minutes ago, and so we just kind of ad-libbed a little bit, and we're going to make stuff up as we go. This muscle, push up for me, is the rectus femoris, or the quadriceps muscle. And we saw on a previous slide that it might have associations with the small intestines. There are points on the body called Riddler points, which sometimes mirror Chapman reflexes, sometimes mirror Bennett reflexes, which was just another guy from a long time ago, and sometimes are just superficial areas over the organ involved that can correlate with certain areas of the body. So if I had a potential muscle like the small intestines, related muscle of the quadriceps, I could potentially come over here and jab on an area that correlates with it. And what I'm doing here with this is I'm hitting number 22 area. I'm just having her touch with that. And I'm going to now ask her body, how does this do in the presence of an additional influence, an additional afferent stimulus to your body? And her body says, I can walk and chew gum. Good. That's great. We learned the tensor fascia lata earlier. Oh, we can't use that one. It's not on my chart. Tensor fascia lata in applied kinesiology references to this spot right here. It's just like where the anterior lateral aspect of the upper 1/3 of your thigh. So we're going to have her touch there after I establish that we have a normal tonic muscle. Push up and out. So we have a good, strong muscle. We ask to see if that muscle is normotonically intact. She's now holding that muscle over there. it goes weak like we want it to. That's normal. I can then have her jab on a Riddler reflex or something like that and push up and out. And her body says, yeah, I can do that. So I would think at that point that maybe large intestines and large intestine muscles are doing well. I probably can go on to something else. Unless there was a strong clinical relevance to figure out something about that. Does that make sense? So whenever I'm taking someone's history and they're telling me things, and then I start incorporating muscle testing into the picture, I'm using diagnostic muscle testing, and sometimes I'm using surface level points here. Sit up facing that way. You had a great question in the back about north pole of a magnet. Is that the only side we use? And I said sometimes it is the correct side to use. And we've now identified that the north pole of the magnet causes weakness systemically as well as locally. Can you slide that way just a touch more? Perfect. This is a terrible muscle testing procedure, but I need to be able to see y'all and talk at the same time. If I were attempting to use a straight arm muscle test and I have her push up and she's good and strong, and then I take the north pole of a magnet and test her again and she goes weak, that's excellent. The south pole of a magnet should never cause weakness on anybody. And if it does, it's creating a stressor or a problem in their life. And therefore, we can use the south pole of a magnet as a way to provoke the body for another layer of evaluation. Some people will do this with their fingers and just touch these different Riddler points as they test the body. So you might test and then come to like a lung reflex point and test, and come to like the liver gallbladder point and test. And that's an appropriate way of doing that. I don't like getting all feely with people, so I use magnets to do it. Mostly because if I want to touch certain body parts of people, I don't like my hands getting too close and accidentally groping people and having a misinterpretation of what I'm doing. So I use the south pole of a magnet as my reflex point challenge. But the reason I don't use this magnet when I do it is because it covers such a large area. So my little small magnets that y'all were playing around with earlier are the ones I use when I go into testing reflex points on people in order to figure out how things are going. Let me go grab one of those real fast. So, it doesn't matter which magnet we use as long as it's strong enough. The dot means north pole. If I take the north pole of a magnet and place it over her belly, we see weakness. If I flip it around and do the south pole of a magnet over her belly, we shouldn't be weak. And she doesn't go weak, which is great. So now I can use this magnet. I'm sorry, I'm just gonna have to stand here for a second. If I test her over the lung area and like the top of the brain and the pituitary reflex and the pineal reflex, and I can go through and scan different things on her to figure out what might go weak. And when I find one that goes weak, that just tells me more about her. Does that mean that her right ovary is about to fall off? No. Does that mean she's in menopause? No. Does that mean that she's pregnant? No. It just tells me that the south, are you pregnant? No, I'm joking. That the south pole of a magnet induced a level of strain to the area. And now clinical brain comes in based off of physical exam, based off of history, based off of labs, based off of questionnaires, based off of everything I know about her. And now I can start doing something about it. Just out of curiosity, let's pretend you played with this on Monday morning and you took a large magnet and you put it over the ovary area and you pushed on her and she went weak. What might you do to try and see if you could create a strength back into her life with that reflex? Possibly a glandular is what Ashley said, but Liz also said simplex F, which is a type of glandular. Ovotrophin, glandular stuff. Maybe liver stuff. You might be thinking in your mind though, like how might I support the female reproductive system? That's a very logical thought process. You might think to yourself, maybe I'm pushing too hard because I've only done this like for 3 minutes one time on a Saturday. And so you might reevaluate by checking other places, right? So that might go through your mind. And you might say something like, maybe she's got like a muscle spasm in her rectus abdominal muscles because she did core workout today. And that might be a plausible explanation for why that happened. We have no idea other than the south pole of a magnet in this area attempted to cause something to go weak. So we play with it. So let's play with it. Let's pretend, hypothetically, we grabbed simplex F because simplex F was glandular related stuff. It helps support the female reproductive system. We'll have her put that on her tongue. We will then take her arm, push up. Good. She's got her strong muscle. We didn't cause hypertonicity. That's fun. South pole did that. So I flipped the magnet, sorry. I should have explained that. Because I checked. I put it on her tongue and I wanted to say, guess what, Chase? Did you possibly break her? Maybe I sent her into a hypertonic state, and no matter what side of the magnet I use, she's going to be strong anyways. Whew, that's mind-blowing. If you've ever done muscle testing before and not considered that the thing you're doing causes them to be in a hypertonic, non-testable state, and we're only relying on the muscle test to tell us if we're doing the right thing or not, I might be jacking her up and thinking, oh, I'm so awesome because she's strong now. But I may have induced hypertonicity. So instead, I checked that first. I said, north pole of a magnet over muscle I'm testing causes weakness. Okay, we didn't create hypertonicity. North pole of the magnet over the belly didn't create systemic hypertonicity. South pole of a magnet over the spot we checked a minute ago, she's strong. My level of confidence to give her simplex F has dramatically gone up now. If it makes sense clinically, if she can afford the $100 bottle, no, I don't care about that. I just tell them what they need, right? It's up to them to figure out if they're going to afford it. And I don't mean that like facetiously, but like I tell people what they need. And sometimes they tell me, oh, I can't afford that. I say, okay, well, let's see what we can afford so we can help you get better. So we're going to get off of everything that tastes good. We're going to lower our carbs. We're going to, go to sleep at a normal time. And maybe we won't have this reflex showing up next time. Maybe we don't need a bottle of Simplex F. But if it comes back next time, I'm going to recommend again that you need this thing because it makes our symptoms better. And it tastes good. It's like salty and it tastes awesome. It's not too bad. So that was a good thought process. Whoever said, let's try some glandulars in Simplex F. I don't know anything about Ashley's clinical presentation or if that's necessary right now. But as I start diving into knowing more about her and using a magnet reflex with the south pole over different areas, we found a hot spot that her body couldn't tolerate well. We then attempted to change that hot spot with something through a neurologic-based gustatory challenge. I made sure that I did not create or induce hypertonicity, and now my confidence level has gone up and up and up, saying Simplex F is probably a good thing for you, and I'm doing little to no harm as a result. Pretty fun, right? If you're into it, why not? We go and spit that out. Maybe you don't want a salad bar of supplements on your shelf. And so maybe you've seen this thing here all night and just wondered, what in the world is that thing behind him? If only these were in alphabetical order. I'm just joking, they are in alphabetical order. I just don't know my alphabet. All right, Liz set this up for me yesterday because they were not in alphabetical order before. They were in alphabetical order this way, A through Z, and it was just counterintuitive to normal people. So Liz fixed it for my life like she always does. We have a strong testing muscle. We have the north pole of a magnet over the localized muscle, and we see that it goes weak like we want it to. We're normotonic locally. We check the north pole of the magnet over the solar plexus area, and it goes normotonic systemically. Your arm okay?
Yeah.
You want me to switch arms?
Nope.
Come to south pole of a magnet over that area where we just were. It's back to being weak again because she's not getting a continual reinforcement of her nervous system saying that, hey, this is a good thing. I ask her to quietly hold something. And I re-challenge that. And energetically, Simplex F did the same thing as when she was tasting it. In my office, I will bounce back and forth between real oral taste response and energetic reflex testing. I primarily do oral-based challenges at the beginning when I'm establishing rapport and relationships with people. And then they just kind of see that I'm weird, but they're getting results, so they don't care, right? I personally find in my worldview that I don't do energetic testing on the first visit because I don't want to potentially scare someone away. And I know that's not the case with everybody. I know some of my friends, they sit down and they're like, you don't even have to fill out paperwork, just give me an arm. And they just start testing people. And I get that. It's not my worldview. So the way in which I do things helps me to bridge the gap from someone who's never seen a functional medicine alternative, weird applied kinesiology doctor before, and the expectation of what they think they're getting when they come in, which is, I'm going to see the chiropractor today, right? And so when someone walks in off the street, their friend sometimes says, oh yeah, Chase is going to do some weird stuff, just go with it, it'll be perfect though, don't worry about it. And sometimes they find me on Google and they say, oh yeah, I'm here because you're a chiropractor and you have good 5-star reviews on your website. I'm like, okay, cool. And then we start a process. Hey, I'm going to do some evaluation. I'm going to check some range of motion. I'm going to do some basic orthopedic testing. I'm going to poke on you. Hey, that's weird. Does that hurt? Yeah, that hurts. Okay, here, we're going to do something weird. I know it's a little bit different, but put this on your tongue. We're going to try and create a neurologic-based response to see if I can create change. On the tongue, it feels better. They're like, wow, that's crazy. And I was like, I know, that's weird. I wonder what happened. And then they're excited about it. They see something different. And I tell them, we're going to do something different because you've never had this before. I want to make sure I get to everything that I know what's going on. Get you to your wellness goals. We're going to now evaluate some manual muscle testing. These nerves from your body tell you what to do, and they branch off, and a branch goes to the muscle, and a branch goes to the organ, and a branch goes to the skin, and a branch goes to the gland. And we're going to just see how your nerves are telling me what they're doing. And I'll do a full body evaluation of muscle testing things through diagnostic muscle testing. Hey, that's neat. Watch what happens. I can make this muscle go weak. But instead of bruising you the rest of the visit, I'm going to introduce a new concept. I'm going to take this magnet. Watch what neat thing happens whenever I put this north pole of a magnet. Oh my gosh, it's weak. Yeah, that's neat. That's a cool trick, right? But it tells me you're testing properly from a neurologic standpoint. And I'm just building my visit into the weirdness, so that by the next visit when they come in and I sit down and say, remember last time we took this magnet to you and it shut things off? They're like, yeah. It's like, I've got a plan that I think I want to do to you. But I'm going to test you specifically to the plan that I laid out to make sure that you resonate well with what I'm about to do to you, so that you have fewer reactions and we have greater success. And they're like, okay. He's like, remember that magnet causes weakness? They're like, yeah, it's so weird. I told my husband about that. That was the craziest thing. He's going to come see you because he doesn't think that you can do it to him. I was like, that's fine. I'll test him on it as well. I was like, see how that goes weak? And they're like, yeah. And I remember, this is another spot it causes weakness. And they're like, wow, that's so crazy. I'm like, I know. And watch this. When we take things and we put them in your life, and I go back to some of these, I'm sorry, let me rephrase that. We take this arm and it's strong and we know that you're working like I want you to. I want to just challenge a couple of those spots that were painful on you the other day, or that might go clinically relevant to your specific pattern of weakness. And wow, we found a spot here that's not working like we need it to. Will you just hold this for me? I know it's a little bit weird, but I want to see if energetically your body resonates well with that. Hey, it does. That's cool. That was on my list of things I might want to give you, and I just needed to double check. And that's how I take people to bridge them from the doctor sees me for 2 minutes after sitting in a room that's cold and the nurse takes my blood pressure for an hour, to I'm now going to ask you to take supplements and change your diet and do the things that I'm asking you to, because that's a different pattern of healthcare. And I want to slowly bridge them through the process so that I don't just walk in and say, Ashley, it's nice meeting you. My name is Chase. You can call me Dr. Chase because that's what people who do chiropractic do. We also use first names. And I'm going to do these weird muscle testing things, and I'm going to do this, and you have a parasite. Good luck. Like I'm trying to avoid that experience. Not because I think it's bad, but it doesn't fit my brain whenever I work with people. So I do things that make sense to me because I'm practicing in my office. And in your office, you have to figure out what that is for you. And that's the hardest thing about coming to a workshop like this, is knowing how do we take it in and make it fit your world. Because if right now you walk in and you heart sound recorder every person, that's a phenomenal tool. Don't give it up to give something else another chance to take its place. If it's clinically relevant, use the tool that you already have that's made you successful. But maybe the next time nothing hard sound recorders, I love them. Next time I had to see some weird ratio of the work to rest ratio, and I think, man, could it be cataplex B core? Could it be cardiotrophin? Could it be simplex M? Could it be this? Could it be that? Now I have a tool to possibly challenge against the person and say, in your body, this seems to work well. All right? Or now, someone comes in and they hand you a stack of labs, and they're anemic, they have hypothyroidism, and they're 30 pounds overweight. And you tell them, I know exactly what we're going to do to help you. We have people like you all the time that come to our office. You're in the right place. We're going to modify your diet in this way. We're going to support your thyroid in this way. In fact, based off of your exam, we found these 3 things to be the most important thing for your thyroid, so that's where we're going to start. And even though your iron is a little bit low over here, it looks like we need to support digestive activity so you get better absorption, so that your iron levels now come up, instead of just throwing more iron at you like every other doctor has done so far. That makes you constipated and your stools are dark, and it just hasn't been working. So if you come to see me and I just give you a fourth type of iron and we get the exact same result as everyone else, I've missed the boat. But now because I stepped back, evaluated the labs, evaluated the physical exam, did some palpation, did some nutrient challenges, I'm more confident in saying, this chlorophyll complex that has 0 iron inside of it, but yet helps small intestine brush border absorption, helps by shifting through chlorophyll into the blood, by exchanging manganese and iron, and helps with digestive absorbability of the food you're already eating, is going to be in your best interest because your exam, your history, your labs, everything tells me that, then now we're onto something. And it's something different that they haven't tried before. By the way, take some Zypan too, because it'll help with separating that iron out. Right? So, but I can do that in confidence instead of just saying, your lab says low iron, here's more iron. I'm like, but everybody else is giving me iron, but our iron's whole food based and it's going to be better for you. And I agree with that statement wholeheartedly. But sometimes we miss the boat because we don't let their body tell us what's going on. Okay? Is that too much? Too much pontificating? Thank you very much, Ashley. You crushed it. All right. If any, do y'all have so far?
Are you going to give us a resource or purchase of a magnet?
Sure, I can. Yes.
Yes, we can.
Liz will write a sticky note for me, and I will make sure that that happens in your life at some point. These magnets are super cheap. They're like 10, 15 bucks maybe on Amazon. No, Granger. Granger is where I buy these magnets from. Granger. And so Granger, nobody thinks of Granger for medical supplies because it's a non-medical supply place. You buy like motors there. But growing up, I worked in construction, so I know you could get stuff like this from them. So I just looked up the magnets that I bought at other seminars and measured them out, and I was like, I know where to find those a lot cheaper.
By looking at it, or is it a certain weight?
It's outside and inside diameters with a certain pull weight are what I'm focusing on. So I'll just send you the link, and they're like 10 bucks or something from 12 bucks. Yes, but Liz will remind me to make sure I do that. All of you will get these slides that we did and went through, and I'll make sure to include a magnet. All right, we've kind of exceeded our time, and I apologize for that because we didn't go through a portion that we wanted to, or that I was hoping to get through. And I don't know if we have to leave now, or if y'all want to leave now, or what the rules are. We need to figure out if we have to be kicked out by like 1 o'clock, because we're 4 minutes from 1. But if you want, for the low price of just sitting a little bit longer, I will demonstrate a different thing that we haven't covered yet that can be included with Riddler reflexes or stand independent of them as ways to ask more questions about the body. And it involves provocation vials. So, kind of like we just had Ashley hold simplex F and it created a reflex change, we can sometimes use bad guys instead of good guys to see how the body handles things. Christy, how are we doing on time? Everybody is just chomping at the bit to stay for at least 3 more hours. No. No, if I can get like 10 minutes, I think I can describe it, and then nobody will have a chance to play with it, but I can describe it.
I'm not sure I'll have to ask the front, so just go ahead and.
Okay, we're just going to do it then. All right, perfect. All right, thank you. So up until this point, our main premise has been find something that doesn't work and see if we can get it to work better, right? Muscle is strong, it goes weak like it's supposed to, move on. Muscle is weak, how do we find something to get it to work better? Well, if we have a normotonic muscle, a good solid foundation, we can now use that body part as a question and asking device. So, Kyrie, will you come up here, please? This is my daughter, Kyrie. She's our videographer today. Kyrie is mostly doing good. She has a subchondral non-displaced lesion on the talar dome of her foot. So she's in a boot. She's our basketball player. Hurt herself running around doing stuff. Lay on your back for me. Thank you. We won't test the foot for now. In practice, I would test her foot, even though it's got a mild growth fracture on there. I don't care. I'd test stuff anyways. But I'm not going to mess with that right now. But we're going to test her. Arms by your side for me. Push up. And we are grabbing her because we know she specifically hasn't been messed with today. Good. Our leg is strong. It went weak when I asked it to. Push up for me. Good and strong. Push up. Goes weak when we ask it to. Great. You don't have your phone in your pocket? No. Good. North end of a magnet right over her belly, push up. Goes weak when I want it to. Systemically testing like she should. Local to the area, push up. Goes weak like it should. I've got a good strong muscle there, push up. Good muscle there. Good. I've got some good testable things on her. So now, I can come over here to potential provocation vials. And these are vials that are energetically messed with to try and recreate or represent certain things. And I'm going to challenge her body to some of these. And we'll just say like, hold those for me. Or if we take that category of things, no, you just hold them, that's fine. And she's just holding them. We introduce that into her energetic and neurologic field. Push up for me. It didn't cause hypotonicity as a result.
We have until 2 o'clock.
Perfect. When I put the magnet over the north pole of her, push up, she still goes weak. Even though we just stuck energetic things that jack people up, her body seems to say, doesn't bother me. Right? And those things were immune-related things. And we won't go through what they are. But we asked her body, how do you handle these immune stressors? And her body says, I appear to not have a problem with that. Because she continues to test in her normotonic way. Let's try a different series. Other immune-related vials. Push up. Still seems to test okay. Good. And as her father, who sees her never take supplements, I am pleasantly surprised. Push up. We found one. Okay. North pole of a magnet. Push up. Causes weakness. Could I be using her arm right now? I could. I could be using any muscle I wanted to do this. I'm using the leg because we workshopped it earlier. When I take these 4 vials, something displaced her energetic field and caused her to go into a non-testable hypertonic state. So now I'm going to ask, is it this one? Push up. Everybody says, not that one. Is it this one? Not that one. See how fun this is? It's an experiment. We have no idea what's going to happen. But that one doesn't work well. And her body says, whatever that is energetically jacking me up. Because it stopped my systemic reflex from working like it's supposed to. And me, as her dad, pulling out emotional heartstrings, I want her to get better at all costs. You're going to take some beta food. No, I'm just joking. No, but it's one of these clinical things where I'm like, well, shoot, what's going on with her? Is this something potentially stressing out her body to where she's slow to heal? And this is why for the last 2 months she's had ankle pain when she's running around playing basketball? Maybe, maybe not. They have nothing to do with anything that she's told me about her health life. But it's one of these things, it's another puzzle piece that helps me say, in your situation, you don't seem to handle cestodes really well. Cestodes are types of parasites, so that's an interesting concept. So are you parasitically infested? Maybe, maybe not. But I would never diagnose that off of a muscle test with a vial on her belly. If I wanted to know if she had cestodes, I'd run a stool test. But energetically, she's not handling this idea very well, and I might want to support that if it made clinical relevance. We'll do another one, push up. And that one did okay. We've got 3 more from our common immune with the gut system vials. Push up. And those did not do it. So, we now have a new puzzle piece that says, when she has cestode vial in her life, she doesn't test well. Push up. I keep switching between legs just to not let her get tired. Because at the very beginning I checked to make sure I had 2 good indicators. So if you're wondering like why I keep going back and forth, that's why. I just don't want to test the same muscle 43 times in one visit. So I'll go to do this one for a while, then I'll do this one for a while, and I'm just back and forth. But they both tested well, push up, except when they didn't, in the presence of this, right? So now we've got this concept where she's not doing things like I need her to. Well, how might I make a solution? I could potentially come over here and grab Biofilm Pro Balance, which we never found the open one earlier. So we'll just open up our own, because this makes potential, thought, oh, okay, that makes sense to me. So I wrote it down in my notes. I'm in like 3 weeks before even starting try 1 in chiropractic school. Like I'm fresh in there, I wrote it down. And for a year, until he came back into Dallas again, I chewed every supplement I ever took. And I just was like, man, these are horrendous. Like these are so bad. And so the next year I came back and was like, hey, John, you said to chew these. and when they start tasting good, that you don't need them anymore. And I'm like 20 something years old, like I'm healthy, like I'm not overweight, my blood work looks good. I've been chewing this stuff like 3 times a day for a year straight, and it's so bad. When do they start tasting good? And he starts cracking up laughing. He's like, no, man, they never taste good. I just tell that to patients so they'll keep buying them forever. And I was like, oh, okay. I might have to remember that then. So now I jokingly tell patients, you're going to take these until they taste good. They're like, just joking, they'll never taste good. So Digest Forte is a bitter herb. It makes the gut recalibrate. The good news is that in just a demo experience, we're able to find that we can get muscle testing to change. We got muscles to stay testing like we wanted them to. We saw palpation change. And that makes a better clinical picture that says, I'm much more confident in saying she would benefit from Digest Forte, even though I don't think it's bad if I give her Biofilm Pro Balance. Like, who really doesn't do better by taking some probiotics and some garlic and some, gut support? But if I have to make a concession, I'm going to lean toward Digest Forte in her scenario based off of the 3 minutes I spent just poking on her, and have a better, hopefully better outcome as a result of it. Okay? So like I said, I use these magnets all the time in the office because I don't like jabbing people. I don't want to come in and say, how's this mammary reflex doing? That's cool for some people, but it's awkward for me, I guess. And so therefore I will use the magnet and do stuff on people so that I'm not feeling around on them. Cool? All right. I apologize for going over. Hopefully I didn't go just too fast for everybody, even though I know it's like a fire hose. Hopefully you go out today and you think, maybe I can see that elephant a little bit differently. Maybe it's not a rope after all. Maybe it's not a wall. Maybe I can zoom out a little bit and incorporate a little bit more of a viewpoint with the patients. And we can use these various tools to be able to do it. So thank you all for coming. It was a lot of fun. Look forward to hanging out with you all again in the future. You all have a good day. When y'all get your notes eventually, there will be stuff that we never even covered. So good luck. You'll do fine though.
Thank you.
All right, no problem. Y'all have a good time. Thanks for coming. It's right up here. And it starts talking. Listen to it and see if you can hear me. Test, test, test. Can you hear me? Use the other one also. Test, test. Kyrie, can you hear me? Yeah, because I don't have it on stereo. I only have this one. Because I have a second one that would be the left ear. This is the right ear. So it's not going to be in stereo, but it'll work there. Perfect. I'll get it set up.
Okay.
Perfect. So see how that works? Now turn it off for me. Don't record anymore.
Oh, wait, it's a different button.
Nope, it's the same button here.
A little bit of breakfast. The breakfast was light. I'm sorry if there's not enough. Hopefully there is. So welcome everyone. Most of you know me here. I'm Christy. I'm the territory sales manager for Houston. We also have Allison Spellman here. She's in the back. She's our inside sales rep. So I know that we do have a couple of new accounts here, and also some accounts that work with Allison. So definitely make sure you talk to her, introduce yourself to her. She is inside sales, so she basically is just like me, but she's in a remote position. So I'm the one who goes out in the field and comes into the office, but she is she's such a vital has such a vital role in supporting you guys and supporting me. So make sure you connect with her. So today we have this workshop. We are going to be doing a lot of breakout sessions, a lot of muscle testing, a lot of practicing. So you'll get an opportunity to take breaks really whenever we do those breakouts. So we don't have an official break time. Make sure that you did sign in on the sign-in sheet and put your email. What we're going to do for today's presentation, this presentation was created by Dr. Chase Hayden, who's going to be presenting today. This is not a standard process presentation. So I cannot send you these slides. So what we're going to do is Dr. Hayden is I'm going to collect all the emails, and he is going to email you these slides from him. So you will have access to that. And that's also why we didn't print them out, because they're really long. So I would say, probably don't take any screenshots or anything like that. You will get them emailed to you, so you don't have to waste your time clicking and filling up your photo album in your phone. If you look at what you have here in front of you, so I do have a printout. This is Dr. Hayden and Dr. Aaron Chapa, who's not here today. They created this practicing nutritional strategies for the basic nutrition strategies for the practicing clinician. And this is their reference sheet for products and the palpation points. So we did go ahead and print that off for you. I recommend keeping that. You could laminate it and have it in your office as a nice guide. And then our promotion for today's workshop, I printed out for you. We are doing a promotion. We will run this through next week until next Friday. So we're going to give you a full week. Or actually, I put Wednesday, May 14th. We're gonna do it till Friday. So if you purchase $500 worth of gold standard products, now the gold standard products are listed below. These are products that we are focusing on this year, and they hit every category, every health category. You will receive 1 canister of glucose assist or a powder of your choice. And I'll tell you why we're doing the glucose assist as the promotion here in a minute. And then, if you double your order, so if you do $1,000 worth of the gold standard products, so again, is going to be presenting today. He's a practitioner here in the Cypress, Houston area. I've been working with him closely for a couple of years now. And he's actually done this presentation a couple times for us, and it's really amazing. So you guys are in for a treat. If you need anything, Allison and I will be in the back. So without further ado, Dr. Hayden, thank you so much.
Thank you. All right, everybody. Perfect. Oh, no, go back. Perfect. 3 seconds in and I've already messed up. All right. Hey, everybody, I'm Chase. Thanks for coming out. Our goal today is to make sure you can leave with tools that you can use on Monday morning. It's the number one thing we want to be prioritizing. There's nothing worse than going to a conference or a lecture or something and getting a lot of good information that you go home with and you just scratch your head and say, how do I even do this now? How do I incorporate it into practice? Christy mentioned a second ago that we have had some phenomenal workshops lately. So like Greg taught this one. Let's see the other teacher. So Greg was a big part in the heart sound recorder testing that we did. We liked the idea of being able to come and learn, but then also do and take home what we have and implement it into our lives, right? So today there will be some philosophic discussion of why we do what we do, as well as some clinical application that you can use on Monday morning. And there will be some things that are a little bit different that maybe you've seen before or maybe you haven't. But let's get a little bit of a lay of the land, because this is nothing worse than me just talking for 4 hours straight. So I want to know what y'all have. I want to know questions. If you have questions, just ask them and we'll answer them and we'll just make it happen, okay? But to begin with, how many of you have been in practice for less than 5 years? Raise your hand. So about 7 of us, okay? How many of you have been in practice for 5 to 15 years or so? 3 of us. Anybody over 15 years or so? Another 3 or 4 of us. Okay, perfect. So good. So a variety of experiences are here today. And like I said, when you've been in practice for a long time, you see a lot of things. And then you come home and you get excited and you sometimes start implementing that into practice. And then you forget all those great things that you already were doing because you're trying something new. And we don't want that to happen. But on the other hand, sometimes we walk out of a conference or a lecture and we learn something super new and we can just figure out a way to add that to what we're doing, and it just lifts everybody as a result. So the goal of this is to see how we might be able to take something from today so that you can add it into your own practice and that you don't become someone who's trying to practice outside of who they really are, if that makes sense. I'm the only Chase Hayden in this room, and I will practice the way that I practice because that's what makes sense in my own brain. And if you try to replicate what I'm doing, it'll not be satisfactory for you because it's not you. So you need to practice like John will practice. You need to practice like Liz will practice and Ashley practices. You need to be able to make it your own so that you have joy and passion and excitement behind what you do, and then your patients will get better as a result of that. The worst thing we can do is try and pretend to be somebody we're not and try and say, well, Chase did it this way, I got to do it this way, because that's not the case. But hopefully there's something here you can pick up that you're like, you know what, that'll plug right here into the way I see patients, and that'll be beneficial for all of us. So let's think about the patient experience. hopefully, if this decides to work again. There we go. So I do a lot of applied kinesiology in my practice. Applied kinesiology is diagnostic-based muscle testing. I do full body muscle testing as well as straight arm muscle testing with vials and things. But the guy I learned applied kinesiology from was named Wally Schmidt. And Wally Schmidt learned from George Goodhart, and George Goodhart was the developer of applied kinesiology. So my family tree of AK is a little bit shorter than some other people's, but I'm super excited that I got to learn from someone who has a strong background in neurology, in biochemistry, in evidence-based care, while incorporating a different context of looking at the person. So a lot of what I do is built and hinges upon how Wally Schmidt would describe things and talk about them, and the other information that we would get from Goodhart through seminars and workbooks and things like that. So Dr. George Goodhart repeated over and over and over again that one of our most important things to do is to measure, measure, measure. Why are we doing the things that we do with our patients if we don't know if it's going to make a difference? If we think about the stereotypical like chiropractic experience, someone hurts their back, they look in the yellow pages for chiropractor because chiropractors are just back pain people. They show up to your office and they expect you to get their back cracked on the first visit, right? And sometimes people do that and they do perfectly fine with it. But what if there's something else that's causing their back to be jacked up? And we don't measure other things and we just assume that every person is a broken back and every person is a nail and I'm just the hammer that fixes things, right? So therefore, Dr. Goodhart would always talk about the importance of measuring things and not relying on the muscle test to be the determining factor. He would talk about how the muscle test incorporates into your physical exam, your history, your orthopedic findings, your lab findings, your whatever else, and you muscle test. And with all that telling you the same thing, then probably you're on the right track. And so sometimes we get excited about being the best therapeutic practitioner we can be, and we forget to diagnose some things. So I'm going to share this little quick video real fast. Hopefully it works. I've never tried using the video through this button. But hopefully it works. But it's Wally Schmidt and George Goodhart talking from back in the mid-'80s. So it's a little bit ghetto, the video quality. But it's a funny story that talks about the concept of diagnosing and looking at stuff. So let's see if this works. Here we go. Oh, why would that not work? 1 second. Pause. It's all right. We can override it over here. That's why it's not working. There's no volume.
One of the things that you really have to do is you really have to make the diagnosis on the patient. You need to assess the patient fairly. What's wrong with everybody on the tree, but sometimes you have to do the diagnostic work.
Everyone wants to be a therapeutic giant. They end up being diagnostic widgets. Because sometimes we feel that we're a non-mainline profession. We feel we have to justify our business by creating spectacular results. And there's nothing wrong with that. But you are much more successful if you become a very good diagnostician. Don't try to be a therapeutic giant when you're a diagnostic midget. I had a patient come to see me who had seen the best iron nose and throat in town. Iron nose open. She had seen the best, Dr. Will Hudson, the best chest nurse, internationally known as a lung physician. She had seen the best interns. She had a constant cough that kept her from sleeping. Cough syrup, analgesics, enzymes had no effect. Her life was living hell because all she did was cough all the time. Very hard to suppress it. And someone had said, well, maybe Dr. Goodhart can help once in a while, which could be real out of place. And some people said, I have that, and they fixed that by act of fine. When she came in, with a history of having seen all the best guys in our town, I assumed at the moment that they didn't miss anything. And she had an x-ray, she had all the usual tests with this constant cough. And I remember having seen one patient that had gotten a haircut, and some of the hair had fallen into her ear, and she had some wax in her ear, and a piece of hair was actually irritating the eardrum. So I looked in her eardrum, and I didn't see anything. And I thought to myself, why should I risk my reputation do if I didn't know she had been to see all those guys. Maybe they missed something. So, I did another thing, I x-rayed her, didn't find her. And, I decided to start at the top. And I said, open your mouth, and I looked to see if there's any uvular deviation, sometimes weaker deviation, that means the cranial falls. Didn't see that. I checked her pupil for reflex contraction to light. I already checked her blood pressure. I already done the other tests. I said, well, the logical thing is to examine the nose and check for possible turgidity of the terminates and that sort of thing. And she's lying on her bed table, lying horizontally like that. And I had a nasal scope and simply looked in the nearest nostril. Didn't see anything. I looked in the other nostril and I jumped out of the room. Looking back at me from high up on her nasal septum was a bee whose eyes were pretty large. And his feet go out like this and look right at me like that enlarged 3 diameter. And squared the hell up. And I said, I think we're the doctors this time. And the bee was mummified, and the other doctors in here were sitting up, and they looked this way. I looked backward, and it was way up here. And it was mummified, and I had a needle nose spectacle. I tried to tease the bee loose, and his feet were embedded in the nasal mucus. And every time I touched the bee, she coughed. And I finally told her, I said, you see what you have me? She says, okay. The sooner was like, she says, you know, I remember when this started, there was a bee buzzing around. Frog said, crawl up there and must have stung something. Crawl up there and died. Because it was mummified, very dry. But that taught me, always look in any orifice you can, because you never know what you're going to see.
All right. So the reason I share this video, apart from it just being a funny story, and I think it's great, is that think about all the diagnostic stuff he had to go through before getting to the solution. He had a patient, that patient went through all the specialists, and then showed up at his office off of a referral, because that's how everybody shows up in our offices. And then if all of a sudden we just stop and say, oh, well, they've already done everything, let me just shortcut to what I think is going to be the problem, we potentially miss the boat. How easy would it have been for him to just say, well, everybody else who came to see me and had these coughing things, I just adjusted their ribs, did a structural thing, and I was done with it. And then he would have done that 1,000,000 times, and it wouldn't have worked because it wouldn't have gotten to the problem, because he was trying to be that therapeutic giant, but he was that diagnostic midget. Does that make sense? Like how we have to step back a little bit. So today, you all have opportunities to look at your patients a little bit differently. And obviously, we take a patient history. I strongly encourage specific forms of questionnaires like the clinical reference guide forms that are there that you can use, the symptom surveys type of things. I love those because they give you a broad spectrum of the patient, even though they may show up and say, you know what, I'm having back pain, but yet you have them fill out some questionnaires and they're talking about how they're constipated and only poop once a week, that when they do, it's like super hard and it doesn't move, and they get gas and bloating and whatever, and then they say, oh no, my digestion is fine, right? But their questionnaires tell you a different story. So it gives you an opportunity to dig a little bit deeper, but also gives you an opportunity to ask them if they're okay with you taking that on as part of the process. If they only want to see you with blinders on and say, nope, chiropractors only crack backs and don't do nutrition, some patients do that. And you say, okay, well, that's up to you and your practice as to how you're going to handle that. But most of the time, if someone comes in and says, I've got low back pain and I see other stuff going on, I will ask them, say, if I had a magic wand and I could fix this digestive stuff that you wrote out on all these questionnaires, would that be okay too? And they're like, yeah, but I just thought you were a back cracker. I was like, well, I can crack some backs, but we can fix some other stuff too if you're okay with it. So let's work together and get you to be healthier. So I love forms for that purpose. I like to do a lot of diagnostic labs. So I do blood work and Dutch tests and urine tests and do things like that because I think that's fun and gives me more info. I do some imaging as necessary, so I don't x-ray every patient or anything, but if someone comes in and they're not getting better after a few visits, I'm like, that's weird. Everybody gets better when they come to see me, so let's do this imaging and see what's going on, right? So why not? And I do a lot of different physical exam stuff. My practice is built on manual muscle testing, neurologic assessment, and poking and prodding on the patient. And then I incorporate the structural, the neurological, and the nutritional side all into one big whole when I start working with patients. And so I love the idea of finding out more about people. That's why I like the heart sound recorder. That's why I like physical exam findings. That's why I like lab tests, because I want to see the whole so that I'm not missing something when I walk in and say, oh yeah, your back hurts? Let me just spend some time wailing on that for a while. Let's do something more efficient for the patient. So, oh no.
One of the things that you really have to
Time
do
out.
is you really have to make the diagnosis of the patient. You need to assess the patient fairly.
All right. So I'm reminded of this poem. Have any of you ever heard the story of the blind men and the elephant? It's a poem by John Godfrey Sachs. Anybody ever heard that before? I'm going to read it real quick because it's like super short, super fun. But this poem just kind of sticks in my mind all the time. And it says, so this is by John Godfrey Sachs. It was 6 men of Indostan, to learning much inclined, who went to see the elephant, though all of them were blind. That each by observation might satisfy his mind, the first approached the elephant and happened to fall against his broad, sturdy side. At once began to bawl, God bless me, but the elephant is very like a wall. The second, feeling of the tusk, cried, Ho, have we here, so very round and smooth and sharp. To me, 'tis mighty clear. The wonder of an elephant is very like a spear. The third approached the animal, and happening to take the squirming trunk within his hands, thus boldly up and spake. I see, quoth he, the elephant is very like a snake. The fourth reached out an eager hand, and felt about the knee. What must this wondrous beast is like, is mighty plain, quoth he. 'Tis clear enough the elephant is very like a tree. The fifth, who chanced to touch the ear, said, even the blindest man can tell that what this resembles most, my stanzas are off. Can tell me what this resembles most. Deny the fact who can. This marvel of an elephant is very like a fan. The sixth no sooner had begun about the beast to grope, than seizing on the swinging tail that fell within his scope. I see, quoth he, the elephant is very like a rope. And so these men of Indostan disputed long and loud, each in his own opinion, exceeding stiff and strong, though exactly was partially in the right, and all were in the wrong. So oft in theologic wars, the disputants, I ween, rail on in utter ignorance of what each other mean, and parade about the elephant not one of them has seen. And so when we talk about the idea of how we see patients, we sometimes come into the idea of a dogmatic worldview that says all people have parasites, all people have emotional issues, all people have subluxation, all people are in magnesium imbalance, or whatever. We make these assumptions sometimes and we miss the elephant for the parts because we put our blinders on and we step in and we say, this person has this thing because everybody has this thing that presents in this way. And I hope that today we can kind of branch out a little bit and say, you know what? Maybe there's something else going on that we can look at. So, all of us are going to have some type of philosophic foundation in which we enter practice. These are some examples. For example, some people like to have a foundational pillar of certain things like fun, rest, exercise, your environment, your diet, your personal outlook, your mindfulness. And upon that, you start then building on blood sugar and digestion or whatever. Some people walk in and say, you know what? If digestion's off, everything's going to be off after that. And there's no right or wrong answer. We all come to this conclusion on how we view the world in our own ways. In a lot of alternative fields, we think about this triad of health where we think about structural and chemical imbalance. You know, D.D. Palmer talked about it, George Goodhart talked about it. And within that, you have a variety of areas that you might use to therapeutically support those different sides or identify imbalances within those specific sides. And all of us are going to have a foundational concept in which we see our patients. I trend in this idea a lot of times, and sometimes I don't. I have a different triangle that I keep in my mind that's the neuroinflammatory neuroendocrine immunology triangle. And so sometimes I keep that in the back of my mind as I think about the neuroendocrine immunology complexes with patients, because there's a lot of research that shows that low testosterone can be a hormone issue, but it can also be an immune issue. It can also be a neurologic issue. So it makes sense in my brain that something like that could be addressed in a variety of ways. And my mind shifts through these paradigms at different times when I see patients, depending on what I'm trying to work with. But ultimately, we have to come up with an idea on how we might treat patients. Because I do a lot of muscle testing, specifically diagnostic muscle testing as taught by the International College of Applied Kinesiology, I keep a strong neurologic framework in everything that I do. Even though I do straight arm testing with vials and things, which are a little bit harder to describe with neurologic-based rationale, I love the idea of looking at the body in a different way through muscle testing. And we're going to hone in a little bit on that today as an idea of how we might support our patients. I'm going to show you some basic muscle testing ideas from a whole body standpoint before we jump into more isolated individual muscle testing with vials and things like that. There's a phenomenal paper written by Wally Schmidt and Sam Yannick about the neurologic rationale behind muscle testing. If you get really bored and like to read peer-reviewed medical research, this is a phenomenal one to check out. But it discusses the neurologic rationale of what we do when we assess patients from a neurologic basis. Our nervous system is heavily influenced by our afferent world. The sensory input we give ourselves directs a lot of things. So we will compensate in a variety of areas, whether that means down-regulating vagal tone and diminishing enzymatic secretion from the gut, displacing peristaltic movement, or imbalancing blood flow to the digestive system due to a fight or flight reaction in our sympathetic overdrive based off of our environment. Those things will happen, right? Or hormonally, we will have downregulation of hormonal glandular excretions as evidenced through parasympathetic tone to the nervous system based off of our afferent influence. So manual muscle testing dives into that world and how does the muscle test change relative to the afferent stimulus that's given to you. And we're going to go into some more of these ideas. So before we get too far down the rabbit hole, though, let's think about normal physical exam. Every new patient that walks into my office goes through a physical exam. We're jumping into like Monday morning application now, right? So every patient comes through my office. I have them fill out about 10 pages of paperwork for their exam because it's a lot of questionnaires, it's a lot of history, it's a lot of tell me about you. But at the very beginning, I spend the highlights. I do my OPQRST like you learn in school, and then I leave those questionnaires for after the first visit because I want to look at those a little bit later and compare what I find in my exam to everything they told me about it. But eventually they get on my table, and we have an opportunity to go through some stuff. And because George Goodhart brainwashed me to measure, I do a lot of basic stuff. I range of motion, I orthopedic finding people, even if they feel like they're doing good. I just check some stuff on them, see how things are working. And remember, all y'all will get these slides. I don't mind if you take pictures, whatever, but you will get these slides emailed to you on our first workshop. I'll get them to you in just a bit. But with every patient, I go through something that is called the Nutritional Physical Exam. And I do a very abbreviated version on everybody and a much more elaborate version on other people, depending on what I'm trying to do and what their specific symptoms are. But we're going to learn this today if you've never seen it before. And we're going to give opportunities for you to practice on each other to see what happens when someone jabs on something and if it hurts. Because the theory behind these are that Chapman reflexes and viscerosomatic reflexes are going to manifest a symptomatic presentation for the patient that's on your table. And that through that compensatory symptomatic change, their body is going to tell you a scenario that we're going to go through. So I do all of the nutritional testing on everybody, but when we go down further down the line, we're going to build in this idea of this hypothetical patient that walks in and says, my back's not feeling good. And how we might evaluate that low back a little bit differently using palpation, manual muscle testing, nutritional interventions, and other applications to help this patient get better. Does that make sense? So, Dr. Chapman came up with these. Boring, boring, boring. Y'all can read that later. Basically, it means we got small intestine points. Basically, you just go to the area and you start jabbing on stuff. Then you go to the large intestine area and you start jabbing on stuff. In the corners, you've got these valves where they're transitional areas where stuff tends to get stuck. Ileocecal valve, Houston's valve. We're going to just jab on things. We're going to palpate the person very similar to how you might do something else with joint stuff or whatever, you're going to do it on people. For the females in the room, we'll jab your ovaries. For the males, we won't jab your testes. Different doctor does things like that, right? So we're going to poke on areas that make sense to poke on. We're not going to poke on others. We will jab on everybody's chest, though, not just the females. We will check men and women, and we'll see what things are sensitive. And the reason we're going to do this is because we want to know where is our body giving us a symptom that's potentially messing something up. Okay, we're just going to start with this at the beginning. Does that make sense? Can we start with something like that for just a second? Give everybody a chance to stand and walk around? We're going to go around and do that for a second. No, we're not. No, we're not. I'll change my mind. We're doing something different. There are two of us that have never seen this before. Is that correct? Everybody else has seen this of some kind. Okay. Then, bear with me. We're going to just go to the next section before we workshop. Because if most of us have seen this, we want to actually do something that's clinically relevant. And not that I want to mess up Terry, I can't remember your name tag. I'm sorry? Simile. So we don't want to mess y'all up.
Okay.
But you're going to be good. We'll see this in a second. But the big question is, who cares? If someone comes in and says, my back hurts, and I'm jabbing around and I find chest tenderness, and I find sinus tenderness, and I find that their ovaries don't work, and I find their Murphy sign, like who cares? Does that really involve their back at all? Maybe. Maybe. It could. It could have nothing to do with everything. Nothing to do with anything. It could have nothing to do with anything. But it could be something. So it's a data point. If you can imagine puzzle pieces, we just got a new puzzle piece we added to the picture. And then a new puzzle piece. And then a new puzzle piece. And if all those start telling us the same thing, well, then it matters. And if we have, a starry night over here and a clown over here, well, then it may not apply. Unless it's it or something weird. And now they might apply, so we'll see. So we have this story. So now what do we do about it? Because I like nutritional things and I treat everybody structurally, neurologically, and nutritionally in my office, I like to figure out if there's a nutritional component to the viscerosomatic reflex that I might be finding. And in conventional applied kinesiology, there is a way to put stuff on people's tongues and let the afferent nervous system change the body. If you like reading neurology, there's a simplified picture there for you to know what you're doing. But ultimately, when you put something on their tongue, you create an afferent change, potentially, that creates a viscerosomatic response, potentially, that will change the palpatory finding, potentially. That's what we're going to play with first, okay? So now, these are all the spots superimposed into one person. These are a lot of products to play around with. So let's just run through some brainstorming in case some of us are not familiar with standard process things. Let's pretend I jab on someone's gallbladder area and they say, ow, that hurts. I then ask them, how does that hurt? It's a 6 out of 10 hurt. I say, great. If I wanted to potentially create a therapeutic thing to help that person, what's something you might do if someone's positive Murphy sign was present?
Beta food?
I'm sorry?
Beta food?
Beta food. Why beta food? It's got beets, it's got carrots, it thins the bile, it helps drain that sludge through phase 3 detoxification, right? Beta food's a phenomenal idea. Anyone else have an idea?
Cola.
Colocol? Why colocol? I didn't hear you say that.
Biosalts.
Oh, biosalts. Biosalts. So if they're sludgy and they're not creating biosalts efficiently or they're not releasing them appropriately, either due to a stone or to just viscosity issues or whatever, I might be able to put biosalts in their line and just start breaking up some stuff for them to give them to break while they're getting some stuff through there. So maybe beta food, maybe AF beta food because it's a combination of vitamin A and cataplex A, cataplex F, and beta food. Maybe biosalts like colocol. Anyone else have a thought on like gallbladdery things? What's something that no one in this room would know that you like for gallbladder stuff? Something that only you use it for. Anybody have a thought there?
Essential fatty acids.
You might give them essential fats, so like the cataplex F or tuna oil or oprena, something like that, which is possibly crazy, but possibly awesome, right? Because when you think about someone who's got a stuck gallbladder, you say, well, maybe I'll give them some more fats, right? That sounds counterintuitive, but maybe that's going to work for them, right? The good news is we don't know until we try it. But is there something that just some of you think like, man, this just saves my bacon whenever I give someone with gallbladder issues something, and you've only heard it from like one person, and then you're like, I'll try it, and it worked. Do anybody have anything like that for like the gallbladder area?
I use Antrim.
Antronex? Antronex is lovely. We often think of Antronex as histamine and anaphylaxis or hives or liver and things. But gallbladder drainage stuff, it works for Liz. So Liz would use Antranex off-label if she had a gallbladder stuff, and that comes from clinical experience, right? And all of you have clinical experience, and I hope we get to share some of these crazy things around. Because hopefully, if you never thought of Antranex for gallbladder stuff, you might today now write that down and say, ooh, I might need to try that one sometime. Because I've got someone with a stuck gallbladder, and I've beta fooded the snot out of them, and it just doesn't work. Or I've cold them to death, and now they're getting like nauseous, and they're like burping up bile, and they're pooping black stools, and nothing's working because it still works, right? And then you're going to stick one in, possibly Antranex, and then go, holy crap, you're the best doctor in the world, I'm so glad I came to see you. You say, yes, I'm going to tell Liz next time because that was legit, right? So all of us are going to have things like that. For what it's worth, I think Thymex. There is so much infection that just hides out in the gallbladder because when it gets stuck, I find so many people with Thymex that get better with a Murphy sign type of test that I would not ever have thought about that, except one time I was talking to somebody and he's like, oh yeah, I had these bile stones, and when they pull them out through surgery, someone got the bright idea to check for infection, and they just cultured a ton of stuff. I was like, oh, that's weird. Who does stuff like that? He's like, I don't know. The patient wanted to take the stones home. The guy was like, whatever, and she just gave him the stones like from the hospital instead of throwing them away or doing whatever hospitals do with them. And that lady like put them on petri dishes and like wanted to see if stuff would grow, and stuff grew. And she was like, oh, maybe it was really an infection that did this. And it was this weird conversation with the patient. They talked to this doctor. This doctor was talking to me one time. So now I think, maybe I should check immune stuff when people have sludgy gallbladders. And I like Thymex for that purpose. So that's some of those weird pearls that you might use, and it may never work in your practice. Maybe that's not my office where people show up in Cyprus that have gallbladder and Thymex relationships, right?